خلص معي هذا نفسه، بس تعمل لي جوينت، تعمل لي جوينت، لا ما انت الحين.
بس تقدر توجهها اكثر لعندي لانه مايل كثير.
فهمت عليك صحيح والله.
يعني راح تكون.
طيب خلينا نشوف الشب بس.
اهلين معلم.
تمام.
ابدا هو السبيكر من لندن from London. GS excellent. excellent. Professor Popat, are you hearing us? Okay.
Yes, I can hear you. I can hear you very well.
We will start today our first session, and we welcome everybody on the second day of our annual meeting. With us is Professor Sanjay Popat. He's a consultant medical oncologist at the Royal Marsden Hospital and professor of thoracic oncology at the Institute of Cancer Research. His primary research interests include optimization, implementation, and impact of genomics into routine clinical practice alongside developing novel drug treatments through clinical trials. His trial manuscripts has led to global licensing, reimbursement, and recommendation in international treatment guidelines. And he shares British Thoracic Oncology Group Steering Committee and the UK National Specialty Lead for Lung Cancer. Internationally, he holds leadership in the European Thoracic Oncology Platform and the ISMO Society and the International Association for the Study of Lung Cancer. So he will talk to us today about genomics in solid tumors, how to interpret the NGS report. It's a very honorable professor, and we will really enjoy his talk. Thank you. Please.
Thank you very much. Thank you for the very kind introduction and the wonderful invitation to speak. I'm sorry I can't be there in person. So, solid tumor genomics, how do we interpret this report that we have? It's a problem. We only really read the conclusion, right? So we need to understand what the report actually says. These are my disclosures. So cancer, as we know, is a disease of genetic abnormalities. We can have genetic abnormalities which are present in the gametes or the sperm and the egg when we are conceived, which are then present in every single cell of us, even as the fetus, and then when we grow up to be an adult. These are called germline genetic abnormalities or germline genetic variants. Then we can have genetic abnormalities which do not occur in the egg or the sperm, but occur within the body or the soma. They occur at any stage of development of the fetus or the child or the adult, and can occur in any part of the organ of the body, such as the lung or the colon. These are not passed on to the offspring, and these are called somatic variants or somatic genetic abnormalities. Now, in genomics, we have to get the language right. We have to make sure we're talking about the same language. So we don't always talk about mutations, we talk about variant, because the spelling mistakes of the DNA sequence can be different to what we expect in a reference genome. And these spelling mistakes or these variants may or may not have any function change in what the gene does. Some of them can be completely silent. So, for example, a benign or likely benign variant is a DNA spelling mistake or a change in the DNA sequence which has no functional consequences. And they're commonly seen in the population and in our organs if we sequence them. Sometimes we call them polymorphisms. What we're really interested in as oncologists is the genetic sequence changes or the genetic variants which impact on the function of the gene. These are called pathogenic variants, and they are the important ones, and we sometimes call these mutations. Sometimes we see a genetic change, we don't know what it does. We've never recorded it before, and there are insufficient data to be conclusive about its impact on the gene. And we call these variants of unknown significance, VUS. Now, that is true for today in February 2024, but over time, as our knowledge becomes better understood, we will reclassify these as either benign or pathogenic. So today's VUS is tomorrow's druggable target. So the other concept we have to understand is that pathogenicity and druggability are not the same. So if you have a change in the genetic sequence, a benign variant, it does not typically cause cancer. and you can effectively think about ignoring it because it might be genomic junk. We have variants of unknown significance. You can ignore them from the treatment perspective. It doesn't make a difference to you. Now, we find pathogenic variants, and the lab may flag up to you that it's pathogenic, such as TP53 or P53 variants. These cause cancer, and they're important, but they may not be druggable. And TP53 is a classic example of a pathogenic variant which we cannot drug in the clinic today. Another example is APC mutations in colon cancer. They cause colon cancer, but they're not druggable. Another example is EGFR mutations. They cause cancer, but they are druggable. So understanding the difference between pathogenicity and druggability is really important. So lung cancer or lung adenocarcinoma is a very classical example for why genomics are important. When we sequence lung adenocarcinoma, we find a wide variety of genetic changes that occur within the tumor. These are tumor or somatic genetic changes. They're not germline or heritable genetic changes. These genetic alterations, sometimes called mutation, sometimes called gene rearrangement, sometimes called fusion, they all do the same thing. They switch on the gene, they cause the cell to grow, amplify, and divide and replicate. And because they are activating genetic events, they can be switched off. It's easy to switch off an activating event. It's very hard to switch off an inhibitory event, which is why in lung cancer we have lots of activating events and lots of drugs. So what are the different genetic sequences that we can see? Well, the first classification is mutations. These are simply spelling mistakes within the gene, and they can be called substitutions. Here, G is changed to C, or C becomes T. You can have insertions, or you can have deletions, where small spellings are different in the tumor compared to the reference sequence of the human being. Now, we can have what are called structural aberrations or copy number aberrations. These are called changes in the actual chromosome. Good example is amplification. You can see in the figure that the purple chromosome has lots of the A gene, many copies of the A gene. That is called amplification. Classic example being HER2 amplification in many tumors. Or in the bottom example, the chromosome has lost the A gene and the B gene. This is called a copy number loss, and sometimes you refer to it as loss of heterozygosity. In terms of druggability, amplification is sometimes what we're looking for. The other thing that we can see is called structural rearrangement or gene fusion, and sometimes it's called gene rearrangement. And you can see in the middle figure that the genes of the blue chromosome have switched over with the genes of the yellow chromosome, and that's called a fusion. And we see that quite often in lung cancer, ALK fusions, ROS fusions, RET fusions. Now, when we're talking about the language of genomics, we have to understand that the people in the lab speak a different language to the people in the clinic. Now, the people in the lab have to speak their own language so they can make sure that what is coming out of the lab is the same in each and every lab. And this is called the HGVS nomenclature, called the Human Genome Variome Society nomenclature. And this is so that everybody in all of the labs in all of the world are talking about the same thing. So let's decode this. What it's saying is that in the BRAF gene, you start off with the name of the gene, the BRAF gene, then it goes into C.1799. This means in the DNA location at nucleotide number 1799. What is happening is that the T nucleotide is changing to an A nucleotide. Now, you don't care what that means. I don't care what that means. That means nothing to me and you. But in the clinic, that's important because the next bit is the important bit. It means that that nucleotide change results in a protein or amino acid change. So the P dot stand for protein. So it means that the DNA change at position 1799 means that at protein codon number 600, the valine amino acid changes to a glutamate amino acid. So V changes to E. And all of us will know that BRAF V600E is an important pathogenic mutation, which is then druggable. but it can get very, very complicated depending on what's going on. And so you have all these different terms on the right-hand side which help us figure out what is going on in the actual genetic sequence, such as INS, which is called insertion. You might see FS at the bottom there. That's called frame shift. That's another type of insertion. Or DEL, deletion. That's when part of the nucleotide sequence is lost. So why do we do genetic testing? So why we do it determines how we interpret the report. We can look for drug targets, and that's generally what we're doing. We're looking to see, can we find a drug target? And we're looking for mutations, we're looking for amplifications, and sometimes we're looking for something very, very complicated. That's a genetic signature, where we're not looking at just one area, we're looking at multiple areas across the entire genome to see what the patterns are. And that helps us work out what drugs we should be giving, but importantly, what drugs are a waste of time to be giving and we shouldn't be giving. Sometimes genomics are very useful in making a diagnosis. For example, if I send a sample and it comes back as a MAML2 fusion, I know it is genomically a mucoepidermoid carcinoma. It may not look like it under the microscope, but genetically that's exactly what it is. And that helps us how we're going to figure out how we're going to treat it. Now, our hematology colleagues also use it to determine whether we're intensifying or de-escalating treatment. We're not doing that in solid tumors quite just yet, but that's probably where we're going to be in a few years' time. So we have very good guidelines on how we should be interpreting our genetic results. When the lab produce their results, they should be producing what's called a tiering system. When they present the molecular result, they should tell you whether it's tier 1A, tier 1B, tier 2, tier 3, or tier 4. And that is very important, because if you know nothing, just you need to focus on tier 1 and nothing else, because tier 1 is an FDA approved drug which is active against that genetic sequence. So BRAF V600E is a tier 1 mutation. And that's because we have dabrafenib trametinib approved against V600E in many solid tumors. Now, it could be tier 2, a variant of potential clinical significance. And an example being NRG fusions. We have no drugs that are as yet approved for NRG1 fusions, but we know that those trials are ongoing and are active. And it's going to become tomorrow's tier 1 genetic abnormality. Tier 3 are variants which we just don't know what they do. They're probably junk. We can probably ignore them. And tier 4 are definitely junk that we don't need to worry about. The problem is that patients live for a long time. They can live for 10, 20 years. And today's variant of unknown significance may become tomorrow's tier 1 FDA-approved therapeutic genetic abnormality. And when that patient then relapses, you may need to then better understand what that genetic abnormality is. So the important thing is there are many different tiering systems in use in different laboratories. Is your lab using a tiering system? If so, is it the AMP ASCO tiering system, or is it the ESMO tiering system, or is it another tiering system? Make sure you know which tiering system your lab is using. Now, when a tissue is sequenced, there are many different sequencing evaluations that they can occur, and they all have their pros and cons. You can do a single gene test very fast, but it wastes DNA and gives you false negatives. These days, we tend to do NGS, DNA, and RNA NGS, and RNA picks is very good because it picks up what are called gene rearrangements or fusions very, very well. DNA NGS is our classical finding, and NGS is great, but it can be slow depending on who your provider is. And because it reads the entire sequence of all the genes, it can give us questions. It tells us things that we don't even need to know. So it brings us questions as to which genetic alteration we should drug and why. Some genetic alterations have got very good immunohistochemistry, and that's excellent, and we should perhaps be using immunohistochemistry, such as ALK. The immunohistochemistry for ALK is perfect, but some are not so good. ROS1, for example, is not so good, and if you find ROS1 positivity on immunohistochemistry, you must validate it on molecular status. FISH is very good as our gold standard, and it can be very good for copy number gain, but it can also be very good for gene rearrangements. But it doesn't tell us what the actual breakpoints are, and that might be important if we're going to make a decision. So here's an example. This is a 63-year-old gentleman from East Asia, metastatic lung cancer. He's an ex-smoker, negative for ALK and ROS by immunohistochemistry PD-L1. He has something called IDILA Biomarkers assay, very quick. You get a result within 2 hours. It's basically a PCR-based assay. And you can see in red, no EGFR mutations were identified. So what does this mean? Well, the local oncologist said this patient is EGFR wild type, patient needs chemotherapy or immunotherapy. Actually, this is an incorrect interpretation. What we did is a ctDNA. ctDNA will read the entire gene sequence, and we picked up that the patient has an exon 19 deletion, and the patient was then started on osimertinib with a very good result. So a PCR-based assay like Biomarkers will only tell you if what they're looking for is present or absent. It has a a small rate, but it has a small rate of false negatives. So is the case really EGFR wild type, or is it a false negative? That's the question you as the clinician needs to make an answer. So when we get these NGS results, we look at the variant allele frequency. Is this important? Well, yes, it is. It tells us the number of reads of that mutation in the background. It helps us work out what is dominant in that particular tumor. Now, it's important that you cannot quantify amplifications or fusions using this technology, but it helps you work out if what you're seeing, the mutation you're seeing, is present in the tumor or actually present in the individual, whether it's germline or not. Here's an example of a case. So here is a case of a patient with lung cancer. We did the DNA NGS, and they've picked up an exon 20 insertion in EGFR. But it's at very, very low level. It's present at 5% VAF. Now, the rule here is if you've picked up a tier 1 abnormality, which is what this is, even if it's present at a low VAF, it's real. You can action it. So this patient should be treated with amivantamab with chemotherapy in the frontline setting. Patient sees another oncologist. Oncologist says, no, this is very low level. We cannot believe this is true. You must pay for an NGS assay. Patient then undergoes a liquid biopsy. And of course, the liquid biopsy simply confirms the presence of what was there in the tissue in the first place. Okay, so total waste of time, total waste of money for the patient. If you find a tier 1 driver in your tissue, it is real. You do not need a subsequent validation in liquid biopsy. Okay, now, the other question that we get asked a lot is about TMB. Are you a believer in TMB? Some people believe that it is real and we should be actioning it, and some people do not. The problem is that TMB is next to impossible to standardize, and different labs will call the same TMB completely differently. This is a quality assurance scheme of 5 different TMBs, TMB 1, 2, 3, 4, and 5, which were analyzed in 24 different laboratories for TMB according to the Foundation Medicine reference standard. And each of the dots represents the TMB that the different labs called it. So in TMB1, the actual TMB was 10 by Foundation Medicine, but one lab called it 30 and the other lab called it 3. Which one's correct? In TMB number 5, the actual TMB by Foundation Medicine is 65. One lab called it 85 and the other lab called it 15. Which is correct? So TMB is very, very, very hard to standardize across laboratories because of technical aspects. So be very, very careful when you're interpreting TMB if you're a believer that TMB is important. Now, the other thing that we need to look out for in genomics is we're looking for the genetic abnormalities. So we're looking in the foreground, but we don't see what's lurking in the background. We don't see the cheetah that's in the background looking at these deer waiting to hunt. Now, similarly, we need to think about the genetic architecture. So in lung cancer, this is very important. If we have a patient with EGFR mutation, that's very good. I can treat them with osimertinib. But if they have a background TP53 and RB1 mutation, I know that that patient is very, very likely to transform to small cell lung cancer in the future. So that sort of case I need to be very careful about in the future, and I might want to treat them with combination chemotherapy with osimertinib in the frontline setting. In the KRAS mutation setting, we also have to think about the co-mutations, STK11, TP53, CDKN2A, and that might help us work out what type of other therapeutics we think about for that patient. The other thing we need to think about is that all genomics are not the same for all tumor types. So if I see, for example, a BRCA variant in a prostate, ovarian, or breast cancer, I'm going to think about a PARP inhibitor. But we have no data to show that it is the same benefit in lung cancer or mesothelioma. So the on-target effect is very different from the off-target effect. So PIK3CA hotspot mutations, on target, if you find them in breast cancer, very important. You see them a dime a dozen in lung cancer in acquired resistance. They're not druggable. They don't make any difference. NTRK mutations or amplification, it's not druggable. We're only looking for the NTRK fusion. Microsatellite instability. Yes, of course, we're going to use checkpoint inhibitors in endometrial, gynae, and colorectal cancers. But if we find them in meso or lung cancer, does it make a difference? Some data suggest that it's not druggable. One of the bigger issues is that we have is germline mutations. Can we pick these up when we're sequencing our tumor? Yes, we can. But your company report may try not to tell you whether that is the case. So here's an example. Here's a patient with mesothelioma that underwent sequencing. And as expected, it comes back with a BAP1 mutation. This is classical in mesothelioma, and that's a variant allele frequency of 24%. But what can we see? We see a BRCA2 mutation present at 58% variant allele frequency. When you've got a variant allele frequency at 58%, it makes you question whether it is germline. And in fact, we know that that is a germline BRCA2 mutation. We referred the patient, we informed the patient that they harbored likely a germline BRCA2 mutation unexpectedly, referred them to clinical genetics. Clinical genetics confirmed that in their blood and cascade tested the rest of the family. So you can pick up germline abnormalities when you're not intending to do so. So here's an example. This is an EGFR mutation positive patient who is progressing, had first line afatinib, progresses and has second line osimertinib, and then progresses again. So we do the ctDNA. So the first thing that we see is there's lots and lots of TP53 mutation, but no EGFR mutation. So that makes me think that we're not picking up any somatic DNA. But what we do pick up is this TP53 mutation present at 48% variant allele frequency. And what that tells us that is a germline TP53 mutation. So the patient likely has Lee-Fraumeni syndrome, which is probably causing the lung cancer. And we then send them to genetics and have it confirmed, which has big implications for the whole of the family. So of course, these days we're all very excited to use ctDNA. ctDNA is very, very good. We can pick up circulating tumor DNA from many different parts of the tumor in the blood. That's all excellent. And we're using it in many different scenarios. We're using it to identify the drug target at the time the patient presents, if they present with metastatic disease, or if they have had treatment as a resistance mechanism. We're using it in that scenario. We can also use it to see whether, if you've given treatment, whether you've cleared your ctDNA. But of course, you have to know whether you're producing ctDNA in the first place to see whether it's been cleared. It may not have been cleared. Now, we know that that is a good prognostic indicator, but if you haven't cleared it, we don't know whether intensifying treatment makes a difference. So this is not really routine use. MRD assessment after curative treatment, again, not routine use. It might be in colon cancer, but we're not using it in any other cancer at this stage. And of course, our screening colleagues are using ctDNA as screening. The problem with ctDNA is when you find the genetic abnormality, you don't know where it's coming from. Is it the genetic abnormality that's coming from the tumor, the blue genetic abnormality? Is it coming from the germline? Is it leaching from the white cells into the plasma? Or is it just a pre-malignant genetic abnormality that is coming from the red cells, which is leached into the plasma? So ctDNA is very good, but you have to question where the genetic abnormality is coming from. And of course, ctDNA positive patients don't always overlap with tissue positive patients. So some genetic abnormalities we find both in tissue and in liquid, but sometimes they're only in the liquid. and not in the tissue. And that could be because of heterogeneity, or it could be because your tumor tissue is not pure enough to find that tumor abnormality. And that's typical for cases like pancreas cancer, lung cancer, when the quantity of material is very low. Often what happens is we find the genetic abnormality in the tissue, but when we do the ctDNA, we don't find it in the ctDNA. And everybody says, oh, that's a waste of a test. But actually, that's a good thing, because this is an example from lung cancer in patients treated with osimertinib throughout the entire AstraZeneca AURA3 and FLAURA program, is when they did not find the EGFR in the blood, the patients had a better survival. That's the blue line. They have a better survival, better progression-free survival if you did not detect the plasma EGFR mutation compared to if you did detect the plasma EGFR mutation. So it's prognostic if you're not producing ctDNA in your blood. So the rules of ctDNA is if you find a genetic abnormality in the blood, you can action it, it's real. If you don't find it, it doesn't mean it's not there. It could be there, but it's a false negative. So calling a wild type result in ctDNA is very, very complex. And the other thing to note is it's very hard to be sure of amplification in ctDNA because of the technology. So here is a Guardant result on a patient with stage 4 lung cancer who has metastatic lung cancer with metastases to the soft tissue. It reports no reportable tumor findings found in the sample. So the local oncologist says, well, this was a no obvious genetic marker. So this is a ctDNA wild type result. That is the incorrect interpretation. The correct interpretation is this is a non-informative result. You need tissue NGS to understand what's going on with the genomics. Here's an example. This is a patient with exon 19 EGFR mutation with very small volume disease. You can see that the patient has an EGFR mutation, exon 19 deletion. They've been treated with osimertinib. They now have MET amplification. However, MET and EGFR are on the same chromosome. So we don't really know whether it really is MET amplification or whether it's just genomic instability causing increased copy number. So actually, when we did the biopsy in this patient, we found that there was no amplification. It was just copy number gain, and it's not druggable. Now, NGS is very, very useful in helping you make a diagnosis. So here is a lung cancer case, a squamous cell carcinoma case. We see these all the time. This is unusual because the patient had never smoked. They had a resection. We treated them with adjuvant chemotherapy, and then the patient relapsed very quickly. And we're thinking this is not behaving like typical lung cancer. So we then do commercial, this is Foundation Medicine tissue NGS on the resection. And this is a very unusual result for lung cancer because what we see is a Tempris ERG rearrangement. Tempris ERG rearrangement are pathognomonic of prostate cancer. And in fact, it turned out that the patient had a previous history of prostate cancer. So it tells us that maybe actually what he had resected was not lung cancer, but was transdifferentiated prostate cancer. We then sequenced his resected previous prostate cancer, confirmed the Tempris ERG fusion, and what that tells us is that what he had resected was transdifferentiated prostate cancer, which is driven by a Tempris ERG fusion, which is also driven by PIK3CA amplification and loss. And he has this thing called SOX2 amplification, and SOX2 is a transcription factor which makes everything look like squamous cell carcinoma. So the SOX2 amplification is driving the squamous differentiation in what is otherwise a prostate cancer. This is a patient that came to us with a pleural effusion and was told this is squamous subtype non-small cell lung cancer. We did NGS on the pleural biopsies. It shows BAP1 loss, CDKN2A loss, PRMT5, PRMB1 loss. This is classical for mesothelioma. We then asked the pathologist to re-look at it with mesothelioma markers. Indeed, it's positive for mesothelioma markers, reclassified as a pleural mesothelioma. And with that, I'd like to close and thank you for your attention. I do hope that was some use and you're no longer quite as scared by the genomics as perhaps you might have been before. Thank you for your attention.
Thank you, Professor Popat. This is really very extensive experience of yours, and we need to learn more and more about this topic. It's really intricate subject, And as a physician, we didn't used to, for this science to have a background, which it's a new science evolving in front of us. And really, we can help a lot our patients with these methods. And we need more and more to get teaching on this topic. So we can start questioning if there are questions. Professor Abdullah Abadi, he is the head of our society. You want to ask a question?
Thank you for your excellent presentation. My question is the issue of cost. How is this being handled in the UK so we can learn from you?
Yeah, that's a very, very important finding. So in the UK, as you know, cost is a big issue. So we have found that it is actually more cost effective to get the genomics right up front than give the patient the wrong treatment, because otherwise you end up paying for the wrong treatment. So we have centralized our genomics laboratories. There are 7 major laboratory hubs which effectively function like factories that receive the genetic material. On your request form, you say what type of tumor it is. It will be lung, for example, and the sample will automatically undergo DNA and RNA NGS for a predefined group of lung-specific biomarkers. And in lung, we need to know at least 8 different biomarkers for targeted therapeutics. So the NHS has funded that. To be fair, it's not working brilliantly because it takes some time to ship the specimen to the central lab and then the lab to turn it around. But what we're also looking at in parallel is ctDNA. And we've got a health economic program going on at the moment. So what happens is when the patient presents to the respiratory physician, they will have a blood draw for ctDNA. ctDNA, by a commercial assay, takes about 10 days to turn around. And what we have found is that often patients that have a ctDNA positive result have the ctDNA positive result before we've confirmed they have adenocarcinoma. So we can start them on their ROS inhibitor, the ALK inhibitor, the EGFR inhibitor before they have the confirmed pathology. And that specimen then does no longer need to go for tissue NGS. We're working out the costs. We are optimistic it will be cost efficient, but that is the direction of travel that we are in the UK.
Thank you. Okay, Dr. Nadir.
Thank you, Doctor, for this excellent presentation. I have a question regarding when to order the NGS in the early versus in the metastatic setting, and does the change in genetic variation upon metastasis decide when to do, especially there are certain type of tumor, there is no indication to give certain immune therapy or biological therapy in the early stage. So what's your experience?
Yeah, thank you. So I think this differs by tumor type, to be honest with you. I mean, in metastatic patients, I'm a strong advocate for NGS in all metastatic patients because the targeted therapies are often quite useful, and having robust identification of the molecular diagnosis is really important. Now, if you give a patient immunotherapy or chemotherapy, then really the genomics of that tumor are unlikely to change significantly thereafter. So there's no point thereafter doing an additional biopsy for retesting at that point. If you give a patient a targeted therapy like a kinase inhibitor, then that will change the nature of the tumor. So what we generally do is, if you're giving a patient a targeted therapy, we would genotype them before to find the drug target, treat them with a kinase inhibitor, and then genotype them again to see what the resistance mechanism is, to then determine where we go from there. In lung, in the patients that are early lung cancer, we would strongly advocate NGS at resection time because that then determines, what their molecular status is, because ultimately many of these patients will probably relapse at some stage in the future. In breast, you could make an argument that you don't necessarily need to do it up front. You can do it later on at the time of relapse. But if you are thinking about a PIK3CA inhibitor, many would argue that that PIK3CA is not going to change from the time of diagnosis to the time of relapse. So you might as well genotype at the time of diagnosis, so you have that information if they're going to be high risk for relapse.
Okay, thank you.
Thank you. Why we are lagging behind in the small cell lung cancer issue? What's wrong with small cell?
Yeah, so small cell is very interesting biology because small cell is driven by genomic loss. So it's driven by loss of TP53 and loss of RB1. So when you have loss, that then creates multiple other effects, which are then not easy to switch off. So the tumors which are caused by on events, which switch on a gene, are very easy to drug. The tumors that are caused by off events, like mesothelioma and small cell, are very hard to drug with targeted therapies.
Okay, thank you.
That
Another question: if you have two targets, two mutation or variant genes, have you drugged the both of them? Have you used this approach?
Yeah, so it's very rare, but we sometimes find this. We will find two genetic drivers which are druggable. So that creates a problem because you've then got basically a very heterogeneous tumor which has evolved before it's presented to have two drivers. Now, we know that if we give drug one, then the PFS is not going to be as good with two drivers as with one driver because you're not going to be drugging the second driver. So it depends on the type of co-mutations that you have. And it depends on the tolerability of the drug. Some drug combinations can be given together, but some drug combinations are very difficult. For example, with the ALT rise being very difficult to combine two drugs together. So in that setting, it's very useful to do a liquid biopsy because then you can see what the dominant variant allele frequency is. And the dominant VAF will tell you, do I drug the EGFR or do I drug the BRAF? The problem comes when one of them is a fusion because there's no good way of quantifying how much of the fusion you have compared to a mutation, and then it becomes a bit hit and miss. But either way, when you have two drivers, the PFS is always going to be lower than if you have one driver. So we just know it's a more complicated tumor.
Sure, thank you. Any questions from the audience? I think. Huh?
Can I ask a question?
Yes, okay, go ahead.
Yeah, concerning the combination of EGFR mutation and PD-L1. We've been told that if there's an EGFR mutation, you handle this first and leave the PDL to the last. Is there anything variant within the EGFR which will make you use PD-L1 that's ICI right up front?
Yeah, thank you. The short answer is no. PD-L1 treatment is essentially as monotherapy. You'd be doing it on the way to the hospice. We've got very good data biologically to show that PD-L1 if it's very high, it's not reflecting immune activation. It's just reflective of the EGFR biology. And we have a phase 2 trial from the US where patients were all PD-L1 positive and they all had frontline pembro and not a single patient responded. So there is no role whatsoever for PD-1, PD-L1 monotherapy in that patient whatsoever, unless they're on their way. You might want to give it a chance. Now, we have randomized phase 3 trials after osimertinib, where they've been randomized to chemo or chemo plus PD-1. We have 2 phase 3 trials, chemo plus nivolumab, chemo plus pembro. Both of those trials, same result, a non-significant PFS, non-significant overall survival. So there is no meaningful benefits from chemo plus PD-1 or PD-L1. The only time you might consider it is if you're giving frontline osimertinib and then the patient progresses and you choose to use the Empower 150 regime, which is a combination of carbotaxol with bevacizumab and atezolizumab. However, the data for that is a little bit controversial. The license is based on about 40 patients, which many would argue is really not robust, and is a post hoc subset of a larger trial. A dedicated phase 3 trial in China was negative. A separate dedicated phase 3 trial is positive for PFS, but no OS advantage. And in Korea, a dedicated phase 3 trial is positive for PFS, but no OS. And the problem is, if you give checkpoint inhibitor after osimertinib and the patient is on it for a year, after they progress, you're not going to easily go back to osimertinib, because the checkpoint inhibitor, the osimertinib re-challenge will trigger the checkpoint inhibitor toxicities. And that is well proven that drugs like osimertinib and sotorasib, if you use them after a checkpoint inhibitor, they will trigger checkpoint inhibitor toxicities like transaminitis, cutaneous toxicities. So be very careful when using these TKIs after IO preloading.
Thank you. On behalf of the society, we would like to thank you, and we hope to see you in Jordan in person in the future. Thank you.
I would love to. Thank you for your invitation. That's very kind.
Thank you.
Thank you. Bye-bye.
يعني نحكي لهم انها ريكوردد نكشف
جاهز التسجيل؟
Good afternoon, everybody. Our next session will talk about new horizon in the management of breast cancer. Our distinguished speaker is Professor Mark Thill. He is the Director of Department of Gynecology and Gynecological Oncology, spokesperson in the Interdisciplinary Breast Cancer, and the head of Gynecological Cancer Center at Agab Clayson Marcus Hospital in Frankfurt, in Germany. Okay, we are going to start our spoke now. Thank you.
Dear colleagues, ladies and gentlemen, it's an honor for me to present CDK4/6 inhibitor update in metastatic and early breast cancer at the 11th International Conference of the Jordanian Society of Hematology on Hematological Malignancies and Hematology and Solid Tumors. I'm very sorry that I have to present my talk recorded, but for the reason that we have the German Cancer Conference, I'm unfortunately too busy. These are my conflicts of interest. And this is data from the Pregnant Registry, a German big registry treating metastatic breast cancer patients. And you see what happened since the introduction of CDK4/6 inhibitors, that we could lower the rate of chemotherapy first line from 44% down to 16%. And the CDK4/6 inhibitors, they take place in more than 70% of our patients. That means CDK4/6 inhibitors are really the gold standard in first line and second line after prior endocrine therapy for metastatic disease in HR-positive, HER2-negative metastatic breast cancer. The study programs we had seen in the past and had been presented at several, and it's really so many congresses, are listed here. So we have a big study program called Mona Lisa for ribociclib. We have a big study program called Monarch for abemaciclib, and we have a big study program called Paloma for palbociclib. And as you can see, all these studies, they reached a primary endpoint and approval of the progression-free survival. So let's dive a bit deeper in the data, starting with the Paloma 2 study. And we all really waited for promising results regarding the overall survival benefit. So this is palbociclib plus letrozole versus letrozole alone, the final overall survival analysis. We are in the first-line setting. But after reaching progression-free survival statistical significant, we didn't see an overall survival benefit in the Paloma 2 study for the indication of palbociclib plus letrozole in first-line therapy. So unfortunately, no overall survival benefit that was significantly improved. In the Paloma 3 study, palbociclib plus fulvestrant versus fulvestrant alone was given, and unfortunately, we couldn't see an overall survival that was significantly improved also in this study. So therefore, the two studies of the Paloma study program for palbociclib had been negative. So regarding the Mona Lisa study program, we see that in the Mona Lisa 2, in the Mona Lisa 3, and in the Mona Lisa 7 study, we had seen a significant improved overall survival benefit, starting with the Mona Lisa 7 study. And this was a study that was really difficult to recruit because only premenopausal patients, more than 600 premenopausal patients, were treated with ribociclib plus an AI plus an LHRH agonist versus the AI plus LHRH agonist alone. And in the final OS analysis, we had seen a substantial benefit in prolonging for the overall survival of 10.7 months with a hazard rate of 0.76. So statistical significant improval for the overall survival. For the Mona Lisa 3 study, we are now in the pre-treated patient population. So one endocrine line for metastatic disease was allowed. So ribociclib was tested against fulvestrant in combination with fulvestrant, and we could see also an overall survival benefit that was significant of 15.8 months, hazard rate of 0.67. So the second study of the Mona Lisa study program that showed statistical approval of the overall survival. And for the Mona Lisa 2 study, and we are now in first-line setting, so therefore ribociclib was combined with letrozole versus letrozole. Again, nearly 700 patients, we had seen a substantial and statistical significant OS benefit of 12.5 months, hazard rate of 0.76. So that means that all three studies of the Mona Lisa study program showed a statistical approval regarding the overall survival benefit and showed a really high grade of consistency. The third study that was associated with a statistical approval regarding overall survival was the Monarch 2 study. A Monarch 2 study where the abemaciclib was tested in combination with fulvestrant. So all these four studies had shown a overall survival benefit. And we all waited for the last study, so the Monarch 3 study, and had seen promising data at the ESMO 22 in Paris. And now the MonarchE study was presented in San Antonio in December last year. To recap the study design, abemaciclib was combined with anastrozole or letrozole, but 493 patients had been recruited. Patients could participate in the study if they had no prior endocrine treatment, no prior treatment in metastatic disease, and they had to have a disease-free interval of more than 12 months since completion of endocrine therapy. Regarding the updated progression-free survival, you see that it's still statistically significant after a follow-up of 8.2 years, and you see a benefit of 14.3 months, hazard rate of 0.5. So this is similar to the other CDK4/6 inhibitors. But then, as I said, in San Antonio, December last year, the final overall analysis was shown, and unfortunately, no statistical significant overall survival was observed. The problem is really that we have a numerically really high benefit regarding the months, so plus 13.1 months overall survival benefit or overall survival prolongation, but only with a hazard rate of 0.80. The authors, they had a closer look to visceral disease, and they showed a benefit of 14.9 months with a hazard rate of 0.75, but this was also not statistically significant. Let's have a look to the toxicity profile, because now we have to talk to our patients, and this is always a shared decision-making process, that we have different side effects. So we see that neutropenia is really an issue when we treat patients with ribociclib and palbociclib. With abema, we have less neutropenia when compared with, for example, the MONALEESA-2 study. So 74% had a neutropenia all grade. In the MonarchE study, only 46%. But of course, there is another issue for abema, and this is diarrhea. Nearly 90% of the patients suffered from diarrhea when compared to ribociclib, only 35%. So that means that we have differences in side effects and toxicity. We know that we have to have ECG controls when we start treatment with ribociclib, and we don't have, so at the moment, we don't set patients on palbociclib because of the missing overall survival benefit we had seen in the Paloma-2 study. So to summarize the MonarchE study, because this is the first update I had to give you from the San Antonio Breast Cancer Symposium 2023, we see that we have a median follow-up of 8.1 years. Abema was tested in combination with aromatase inhibitors, but the study showed only a numerically longer overall survival without any statistical significance. Well, this is clinically meaningful. This is what I have to say, but as I said, not statistically significant. Regarding toxicity, we had new safety signals. So therefore, it's a negative trial. And we have 4 positive trials. As I said, MONALEESA-2, 3, 7, and MonarchE. In MonarchE, maybe the number of patients is too small to provide sufficient statistical power for significant overall survival benefit when we compare the number of patients in the MONALEESA-7 study with 668. And maybe the MonarchE study will probably be seen as a negative example of poor case number planning in the future. For daily routine, as I said, we have to talk to our patients regarding the data, regarding the OS data and the situation of the different trials. And then we have to talk about toxicity profile, monitoring, and schedule. So we really have consistency in the MONALEESA study program. I think this is what we have to state at the end. So the question is now, is it time for CDK4/6 inhibitors to be set in early breast cancer? And who will benefit from an escalation of endocrine therapy? We know that we have to look to the clinical pathological parameters. And we know that tumor size is a relative prognostic factor and tumor size matters. So the bigger the tumor is, the poorer the prognosis is. But this is not independent on the intrinsic subtype, as shown in very old data from 2009, Rebecca Dent from Singapore. But in the end, we know this from our clinical and daily routine that if we have basal-like tumors, tumor size doesn't really matter. But we are talking about luminal B cancer, so therefore tumor size matters. What else do we have to take into account? Of course, the positive lymph node status. We know the more lymph nodes are involved, the higher the risk of recurrences, so the poorer the prognosis is. And this is really independent on the intrinsic subtype. And this is a really nice piece of evidence coming from the EBC-TCG. 46,000 patients had 5 years of an endocrine therapy, and then the colleagues from Oxford, they measured the risk of recurrence for the following 15 years after 5 years of endocrine therapy. And you see that it really matters with what kind of tumor load you start your patient journey. So for example, if you have a tumor less than 2 centimeters and lymph node involvement of 1 up to 3 lymph nodes, so stage 2 disease, then you have a 20% risk of distant recurrence for the following 15 years after 5 years of endocrine therapy. And regarding a tumor size of more than 5 centimeter and 1, 2 or 3 lymph nodes, or even 4 and more involved lymph nodes, then you have a risk of distant recurrence of 26% or 41% respectively. So this really matters, or it really matters with what kind of tumor load you start your patient journey. The same has to be said for the histologic grade. So if you see a grade 3 tumor, then you have 17% versus a G1 tumor 10% for the following 15 years regarding the risk of distant recurrence. So in the end, we know that regarding the stage, and we talked about stages, so the higher the stage is, of course, the higher the risk of recurrences. Well, this is the baseline from what we think that patients may benefit from an escalation if they have a bigger tumor size and if they have a higher lymph node involvement and a higher histologic rate. So let's dive a bit deeper in the CDK4/6 inhibitor clinical evidence in early breast cancer. And we have to state in the early beginning that palbociclib failed to show any survival benefit. The PALA study was the first study with 5,600 patients that tested and evaluated palbociclib plus endocrine therapy in a high-risk patient population. And 60% of the patient had a clinically high risk defined as 4 and more positive lymph nodes or 1 up to 3 positive lymph nodes and a tumor size of more than 5 centimeters. But as I said, just 60% of the patients. Well, anyway, the primary endpoint, invasive disease-free survival, was not reached. And as you can see, the Kaplan-Meier curves, they are going in a really parallel manner. So it was a negative trial. The second trial, we cannot compare these two trials, was the Penelope B study. For 1 year of palbociclib post-neoadjuvant. And all the patients, 1,250 patients, received neoadjuvant chemotherapy, had a non-PCR, and had an CP-SEG score of 3 or bigger, or of 2 and bigger, with residual tumor in the lymph nodes after neoadjuvant chemotherapy. And then palbociclib was given versus placebo in a 1-on-1 randomization. Again, this study was negative after median follow-up of 42.8 months. And as you can see, both of the Kaplan-Meier curves are crossing and are going on in a very parallel manner. So 2 negative trials for palbociclib. Abemaciclib in the MonarchE study is the first CDK4/6 inhibitor that was approved in early breast cancer setting by the FDA and by the EMA. In the study, 5,637 patients had been recruited, and 100% of the patients had a high-risk situation defined in 4 and more positive lymph nodes, or 1 up to 3 positive lymph nodes, and at least 1 additional high-risk criteria like tumor size of 5 centimeter, histologic rate, and in cohort 2, a centrally tested Ki-67 of more than 20%. But this really doesn't matter for the approval. Here only tumor size and histologic rate and the lymph node status matters. We had seen several analyses in the past, and now the final analysis was presented by Nadia Habeck at the ESMO meeting in Madrid in October last year. And this is from the presentation from the ESMO, and you can see after 5 years of follow-up in the 5-year analysis, the invasive disease-free survival was significantly improved by 7.6%. So after starting the journey with a benefit of 2.8, following by 4.8, following by 6.0, and now 7.6%, this is a really success story for abemaciclib in early breast cancer. I think the promise we give our patients every morning when we get up and go to hospital or to our practices to prolong the overall survival. So therefore, it's very interesting to see the distant relapse-free survival that was also improved by 6.7%, hazard rate of 0.67. So therefore, we could maybe think of a benefit that's maybe statistically significant in the future for the overall survival, but overall survival analysis is not mature at the moment, and you see we have a fewer deaths in the abema arm in the ITT population, but we don't have a separation of the curves. But what we see is that we have a lower number of distant metastases, nearly 50% lower when we compare 138 patients having distant disease versus 269 patients, the first one in the abema arm, the latter one, and the standard of care arm. Regarding Ki-67, I said there was a cohort 2 I don't want to mention because only a few patients participated in this cohort. So the story is Ki-67 prognostic for disease recurrence? Yes, it is. This is something we know, and this is illustrated quite nice in this curve. And we see that if we have a Ki-67 of more than 20% or less than 20%, we have a higher risk of recurrence or low risk of recurrence, but the efficacy of abema is independent on Ki-67. This was really nicely shown at a second analysis at the ESMO presented by Matthew Götz, and you see in the step analysis that the hazard rates regarding the different median Ki-67 values on the left side is really stable. So it is for the estrogen receptor expression and for the progesterone receptor expression. And this gives us the idea that abema works independent on Ki-67 values, independent on ER or PR progression. So let's summarize the MonarchE update. So we had seen the 5-year analysis with continued benefit for invasive disease-free survival and distant relapse-free survival by 7.7% and 6.7% in the, as I said, 5-year analysis. We had seen fewer deaths in the abema plus endocrine therapy arm and about 50% fewer metastases. So maybe the OS benefit can be expected, but of course the analysis is ongoing. We had seen that dose reductions have no impact on efficacy and lead to an improved patient retention, and the efficacy of abema is independent on Ki-67, ER, and PR progression. In comparison to the metastatic disease, we had no new safety signals, and in comparison to the prior analysis. So this leads, of course, to safety. And we know, and this was mentioned by me when we talked about metastatic disease, that we have a diarrhea issue for the patients who are treated with Abema. And you see that compared to the metastatic disease, we have more than 80% of the patients suffering from diarrhea, around 45% suffering from neutropenia. This is an issue we have seen or we see with Abema in this setup. Of course, we have other events of interest regarding venous thromboembolism or pulmonary embolism or interstitial lung disease. We getting more and more familiar with the use or with the increased use of ADCs, but the incidence is quite low and quite rare. Then Erica Hamilton presented a really nice analysis at the ASCO meeting last year from the MonarchE trial with patients divided in two groups, younger than 65 and older than 65. And of course, we see that we have more comorbidities in the older patient population. We have more side effects, but the quality of life is quite stable. But this is something, what I highlighted here with this red box, that should never happen, neither for Abema nor for ribociclib, that we discontinue treatment in our patients who are elderly patients without prior dose reduction. In 19% of the patients, the treatment was discontinued without any dose reductions. And this is something we don't have to do really, especially from what we know that we don't have any loss of efficacy when we perform dose reductions, similar to the data we have for ribociclib in the metastatic disease, that dose reductions really doesn't matter. And it doesn't matter regarding the efficacy of the CDK4/6 inhibitor. So to summarize this block, Abema is an effective and well-tolerable treatment option for pre-postmenopausal patients, also in high-risk early breast cancer patients. At the moment, it's the only CDK4/6 inhibitor that is approved. We have no new safety signals. We have a good tolerability, but not, let's say, a poorer tolerability in patients who are older. It's a standard treatment, I have to say, for patients with 4 and more positive lymph nodes, or 1 up to 3 positive lymph nodes, and a tumor size of 5 centimeters and bigger, or a histologic grade 3. There's one issue, of course, that we start testing our patients regarding BRCA, because we know that if we have a neoadjuvant treated patient with chemotherapy, and this patient is BRCA positive, that means mutated, and then these patients, they have an indication for olaparib, because this is approved, at least in my country, and so therefore we have to test. And we have an indication if the patients have a non-PCR, and we have an indication if the patients with a non-PCR have a CPS-EG score of 3 and more. So therefore, we have to test our patients. And then if we have a BRCA mutated patient, then we have to take into account what to do first. And can we do combinations when we think of Abema? No, this is not the case. We are not able to combine these two drugs regarding toxicity, and we don't have data for that. But for the reason that in the MonarchE study, patients have been randomly assigned with 16 months of definite breast cancer surgery, we do have time in between before we start Abema for 12 months treatment of olaparib. This is what we have in Germany. So just to illustrate that Abema is indicated in the inclusion criteria, regarding the inclusion criteria of the MonarchE study in pre- and postmenopausal patients. And regarding the guidelines, we see that in the NCCN guidelines, it's the same: 4 and more positive lymph nodes confirmed preoperatively or at surgery, and 1 up to 3 positive lymph nodes with either grade 3 disease or tumor size of more than 5 centimeters. We have an indication for 2-year treatment of adjuvant abemaciclib. And this is brand new, the ESMO guidelines. So this is the journal pre-proof. It's not the full published paper, but we see regarding stage 3 and stage 2 early breast cancer, abema can be indicated. But now we come to a very important part of my talk, the Natalie study, because the Natalie study was the third study after PALLAS, MonarchE, where a CDK4/6 inhibitor was evaluated in the early breast cancer high-risk setting. And the first analysis was given by Dennis Lehman at the ASCO meeting in Chicago last year. But let's do a deeper dive in the data of the Natalie study. So phase 3 study, ribociclib for 3 years, when compared to the MonarchE study where abema is only given for 2 years in combination with an endocrine therapy, more than 5,000 patients. And we have some unique features in this study. So not only patients with stage 2 and stage 3 being node positive had been recruited in the trial, also patients who were node negative participated in the trial. And node negative disease, as defined, let's say, as an intermediate risk, had to have a grade 2 disease and an evidence of high risk regarding Ki67 of more than 20%, or genomic risk, so very modern design, an oncotype 26 and more, or high risk via genomic risk profiling in an alternative way, or grade 3. And then, of course, node positive disease. So this study covers a much broader patient population when compared to the MonarchE study. So the dose was not 600 milligram, you may know from the metastatic disease. Instead of the 600 milligram, 400 milligram were used to improve tolerability while maintaining efficacy. And the rationale is certainly that we should be able to maintain the therapy for 3 years, because this was done in the study. And the rationale, therefore, is to drive more tumor cells into an irreversible senescence to avoid these late recurrences we know from luminal B disease. Regarding the baseline characteristics, you see that we have 700 patients being node negative, so 27%. Approximately 50% premenopausal, postmenopausal, and this was before treatment. And then after treatment, we see that the node negative patients were reduced by 400 patients down to 285 patients. So therefore, I'm really interested in the final publication I haven't seen yet regarding the node negative subgroup. Well, never mind. In the second analysis that was given in San Antonio in December, the first one was at ASCO by Dennis Lehman, we have seen significant improvement of the invasive disease-free survival by 3.1% with a follow-up of 33.3 months. And when compared with the MonarchE study and the different analysis that had been presented. So this is quite similar. So let's wait for the next results regarding the endpoint invasive disease for survival that was reached in the Natalie study. Very interesting, I think, because we all are taking into account variabilities or different items when we sit in the MDT to indicate a treatment, that we don't see any difference regarding stage 2 and stage 3 when we take a deeper look in the study. So we can say that ribociclib works in stage 2 and stage 3 disease without any different efficacy. And when I said that I'm really interested in a node negative disease, then we can state at the moment we have the same benefit for node negative disease that we have for node positive disease. So approximately 3% in both groups. Hazard rate is similar, 0.7. So therefore, we have to state at the moment no differences. Regarding the distant disease-free survival, we do have a benefit of 2.7%. So that means that we have a, let's say, 25% risk reduction for distant disease. And again, if we see later on the following different analysis, so maybe we will see an overall survival benefit for ribociclib later on. Regarding the safety profile, we do see a better safety profile. That means less toxicity with the 400 milligrams when compared with the 600 milligrams from the Mona Lisa 7 study program. And this was an analysis that was done at the ASCO last year. It was nicely to see that with ribociclib 400 milligrams, the rate of neutropenia is less, and we see the reduced rate of QT interval prolongation, for example. But of course, to my knowledge, the liver-related adverse events with 26.4% any grade. So this can be an issue, and I do have personal experience from the German ADAPT cycle study where ribociclib is tested versus chemotherapy. And we had seen in a couple of patients liver toxicity that once the toxicity occurs, it stays for 2 or 3 months. So this is something we have to wait for when ribociclib is approved. For Germany, I can say we wait for the approval, and I think we can expect the approval in summer this year. So let's conclude the Natalie study. This is the second study after the MonarchE study to be positive for early breast cancer, high-risk early breast cancer, HR positive, HER2 negative. The invasive disease-free survival was consistent across the key pre-specified subgroups, including stage 2, 3, node negative and node positive disease. Distant disease-free survival was favored for ribociclib plus endocrine therapy, and only non-steroidal aromatase inhibitors had been used. With the data of this study, we now have a data set for intermediate risk patients. That means we have a much broader patient population that can be treated, that can benefit from an endocrine-based treatment, from an escalation of endocrine therapy, if they have this intermediate or high-risk situation. Duration of 3 years is very interesting. The lower dose of 400 milligram is very interesting too, and I hope that we don't see any late recurrences or less late recurrences when compared with what we know. And I think this is very brave to reduce the dose from 600 down to 400 milligrams, but the AMELI study demonstrated a non-inferiority. Currently not yet approved, but it will be approved very soon. So this is my last slide to give you an overview of the international phase 3 studies in EBC, starting with the PALLAS study for palbociclib, as I said, negative trial, Penelope B study in the post-neoadjuvant setting, 1 year palbociclib, again, negative trial, then the MonarchE study, 2 years of Abema, a positive trial, and the Natalie study, 3 years of ribociclib, again, a positive trial. So with that, I have to say thanks for your interest, thanks for listening, and I'm so sorry not to be with you to answer your questions, but I hope to be in Jordan face-to-face in the near future. Thank you.
So we were promised that the speaker can join us in the last 15 minutes to answer the question, but unfortunately, he was not able to join the meeting today. I don't know if anyone from Novartis maybe can answer question. Okay.
بالإيميل.
Okay, if anyone want to ask a question about this presentation about CDK4/6 and comparison between them, talking about the effect of CDK4/6 in metastatic setting and also in adjuvant setting where only ribociclib causing overall survival in metastatic setting and on adjuvant setting. Abemaciclib also achieve overall survival not statistically significant in metastatic setting and in adjuvant setting, and it's the only one that is approved by NCCN guidelines for use in adjuvant setting for nearly 2 years in high-risk patients with breast cancer. And ribociclib is waiting its approval too, and it's used only for 3 years after adjuvant treatment of breast cancer. Okay. Okay. Anyone want to ask any question can send the question by email to the society, and they will send that question to the speaker to answer it.
Break for 10 minutes. Thank you for your listening.
Sure. Then.
Dr. George. حوالي كله ثلاث.
Hello, can you hear me?
Hi, yes, hi, Dr. George. Yes, we can hear you very well and we can see you as well.
Perfect.
But, so, okay, can you hear me good?
Yes, I can hear you. It's quite quiet, but I'm going to listen carefully. I can hear you.
yeah, but no, I'm glad that we can hear you well. We can see also you very well. And my name is Firas. I will be the moderator of our session today. And we are very happy to have you today. And just, I'm not sure if you have ever been with us before in the Jordanian Society of Hematology. Me, myself, I can't remember if you have been with us before.
Yes, you kindly invited me last year, and so I've tried to change my talk around and put in lots of new data for you.
Yeah, that's very good. Yeah, last year actually I was down in COVID, having COVID infection. I could not attend any of the lecture of the event last year.
I'm sorry.
Yeah, I think we will be starting in about 2 or 3 minutes, maybe.
And can you remind me? I've got a 45-minute slot. My assumption is I talk for sort of 30, 35, 40, and then we chat for 5, 10 minutes, or?
Yes, that's the plan. We would like to for you to give a talk like for about 35 minutes, 30 to 35, and then we would give some time for questions for about 5 to 10 minutes. The total time for the lecture would be around 45 minutes in total. So 35 minutes talk and then 10 minutes question.
Perfect. So should I share my slides now, so at least we can bring them up?
Yes. Yes, we see your slides.
You can see them now. So I'll wait and I'll start talking when you tell me to start.
Shall we start? Yeah. Okay. So everybody with us hopefully now back from the break, and I'm very pleased to introduce our next speaker. We are changing topics now to talk about a rather interesting topic, and that is chronic lymphocytic leukemia. I'm very pleased to introduce Dr. George Follows. Dr. George Follows is a consultant hematologist and clinical lead for lymphoma and CLL at Cambridge University Hospitals. He's also an associate lecturer at Cambridge University, and he's the UK chief investigator for a number of clinical trials, as well as a member of the Safety and Data Monitoring Committee for a number of clinical trials. He moved to Cambridge as an LRF Bennett Senior Clinical Fellow and Honorary Consultant Hematologist. In 2007, Dr. Follows was appointed as the Lymphoma CLL Clinical Lead for the Cambridge and Anglia Cancer Network. He also has appointments at the national level, including the chair of the UK CLL Forum and chair of the UK JSH Hodgkin Guideline Panel. Regionally, Dr. Flores was the clinical lead for research for the former West Anglia Cancer Research Network and is now the clinical lead for hematology for the Eastern Region Research Network. His research interest includes lymphoma and lymphoproliferative disorders and management of chronic lymphocytic leukemia. And as I said, with a quite interesting topic, and hopefully we're looking forward to this presentation. Dr. George, the floor is yours.
Thank you very much, and thank you for that kind invitation. And I'm delighted to be able to speak to you and your society again about CLL. Wonderful news for CLL that the data gets better and better, so our patients have more options. And I've updated this slide deck with quite a few of the trials that we've seen maturing through the last year and some new data. So my disclosures are my first. Oh, hang on, not. Oh, sorry, I've got to roll it on the mouse. There we go. Sorry, I'm not that technical. There are my disclosures. So to orientate ourselves, CLL, we are hematologists. We know that we usually make this diagnosis on peripheral blood. We need our flow cytometry, and typically these are CD5 positive, CD23 positive cancers that tend to be a bit weak, CD20. I don't know if in your clinic you use the CLL IPI. I think it's most useful in predicting time to first treatment. A lot of these poorer prognostic markers have perhaps less of an impact on overall survival now than they used to. But I think when you first see a patient, when you've completed your molecular workup, if you're able to run all of these panels, it can help in trying to predict the time to next treatment. And we can see that clearly having deletion of 17p or mutated at TP53, that gives you the highest weighting in terms of poorer prognosis. But also unmutated IGHV genes, we know these patients where the CLL is derived from that pre-germinal center B cell that hasn't yet class switched its immunoglobulins. Those more primitive CLLs, they tend to proliferate faster, don't they? They're the ones you come up to clinic with a white count of 30, and then a few months later it's 50, 60. They have more progressive lymphadenopathy, night sweats. Those are the ones that often end up on treatment. It beats to microglobulin, that's loved by the MD Anderson, and we are testing that more, I guess, now at presentation, then advanced clinical stage and advanced years. So as you accumulate those prognostic points, then you're more likely to be on treatment within the next 5-year plan. And they are quite common, actually. If you're looking, particularly if you're doing TP53 mutation as well as deletion, 17p fish, you've got about 10% of new patients, and about 40% are unmutated. But let's start off with a good news story. And I do like to start my CLL talks with this, because whether you start your patient with a BTK approach, so that's the acalabrutinib frontline trial, or whether you start with venetoclax obinutuzumab, the key thing, these are registrational trials looking at older patients, so median age 70 for the top trial, 72 for the bottom trial. And look, we can see that the 5-year survivals are pretty close to age match controls, and these are taken from the UK life tables. And why is that? Well, both of those strategies are targeting the pathways that we know are most susceptible for patients with CLL. And those of you who track the data at ASH will see that going for BTK and going for BCL2, they are still the absolute favourite targets for CLL doctors.
Sorry if I'm interrupting. We can't see the slides moving. Sorry,
just
wait. Slide is static on the first slide, I think.
Oh, is it still stuck on the first slide?
On the first slide, the CLL IPI stress score.
Oh, why is that not moving? It's moving nicely for me. Oh, I am sorry. So, let me stop sharing. Oh, I am really sorry. I don't know why that's doing that. Let me end slideshow. Come back in, and then I'll start sharing again. So I've got two options to share. Let me Thank you for interrupting me. That's
Yeah, I'm sorry.
no. Now, can you see slides currently?
Yes, we see the slide overall survival in modern trials.
So let
You
me
want
put that.
to move it back and forth. Let's see. It's more.
So can you see it now with the top graph, but not the bottom graph?
Yes, only the top one.
And then bottom one as well?
The bottom, yes, we see the bottom one now.
Oh, perfect. Right. Do please interrupt again. I'm sorry.
Thank you.
So this was a good news story. Look at that survival. And then I just showed you this figure reminding us about the CLL biology. So signaling down through the B cell receptor through BTK, and then BCL2, which is overexpressed in CLL, and it stops the CLL cells from dying. And I think the point I was going to make at ASH is we see all these developments of BTK. We've got the second generation, we've got the non-covalent inhibitors, we've got the BTK degraders. You'd have seen data coming there, because of course the biotech industry is still chasing these pure BTK inhibitors because we know that BTK is so effective. And if you can have a pure inhibitor, then actually your chances of becoming an effective drug with little side effects are really good. And likewise, BCL2, you might have seen some of the new BCL2 inhibitors. BeiGene have got a very interesting one coming through the pipeline. So very exciting as more drugs come our way. Now, this slide I'm showing you here, so hopefully you can see this, is CLL patients have choices. So we've got our most straightforward is the continuous therapy, where we can simply hand out the tablets of a BTK inhibitor, ibrutinib, acalabrutinib, zanubrutinib, those are the licensed drugs. And you can infuse antibodies with ibrutinib and acala if you choose to. And then the other approach, which is right for some patients, is fixed duration therapy. And those are focused around venetoclax, which is paired up with either obinutuzumab or ibrutinib. So let's go on to continuous therapies. And most of us in our clinics the world over have got experience with ibrutinib, and that drug clearly was a remarkable drug. And I always like to start any discussion about ibrutinib with reminding us how amazing it was. And this is the longer term follow-up of the licensing RESONATE trial. And to RESONATE, you'll remember, these are really difficult patients, so median 5 prior lines of therapy. And still, with all of these years of follow-up, they had a progression-free survival that was really quite impressive. And it's worth remembering, because that progression-free survival curve here is perhaps one of the best we've ever seen with ibrutinib. And partly because the patients realized if they came off ibrutinib, their chances of actually surviving were very small. So the patients in that trial tolerated a lot of adverse events. And one of my patients I've managed to get on that trial undoubtedly lived another 10 years. He was a very refractory post-chemo, post-allograft, but getting on that trial and getting ibrutinib saved his life. So why do our patients stop ibrutinib? Well, we know that early stopping is dominated by adverse events, and later stopping of ibrutinib is dominated by disease progression. And what are the adverse events? Well, broadly, we've got cardiac and cardiovascular, so the cardiac arrhythmias, AF, which is something we're all quite familiar with an ibrutinib practice. Sudden death is this devastating side effect that can be triggered by ventricular arrhythmias, and we're going to talk a bit more about that. Hypertension, which is everything for patients on ibrutinib, and even if you're on that drug for 3, 4, 5, 6 years, you've always got to be keeping an eye out for hypertension. And then we've got the general medical things, infection, diarrhea, and bleeding, which is a feature of BTK inhibitors. And we know that there's increasing evidence that these non-BTK off-target the non-BTK off-target kinases are responsible for quite a lot of these side effects. And C-terminal Src kinase is a kinase that is important for electrical stability in the heart, and that is unfortunately caught by ibrutinib as an off-target effect. And then data that was presented just before Christmas at the IWCLL meeting in the autumn. This here shows that ibrutinib seems to upregulate CBP beta, which is a transcription factor that leads to smooth muscle tone increasing. So this tonic increase in arterial smooth muscle tone seems to be pushing up blood pressure. But it was the risk of sudden death. This is what had made a lot of us really quite nervous with ibrutinib a few years ago. And this was UK data that we presented at ASH. And so this is old data, so I'll move through it quickly. But what it showed is patients who were relatively young and fit, so median age 62, those randomized to FCR, we had only 2 sudden death events out of 400, so a relatively low background with 4 years of follow-up. But when we looked at the ibrutinib patients, we clearly had more incidents of this sudden death, and it was enriched for patients who had prior hypertension or prior cardiac history. So those patients, 7 out of 100, so 7% of patients had died with a sudden death event by 4 years median follow-up. And that was not an outlier. It's clear that we see that with all of our particularly elderly patient trials, and I'll be returning to that concept. And so a lot of us using ibrutinib in our practice, where we had the option of moving to second generation drugs if patients have cardiac risk factors, have chosen to do that. And in healthcare environments where you can access the other drugs, then that has been a significant influencing factor in choice. So the second generation drugs, do they have a cleaner adverse event profile? Well, we know in the lab, if you look at the extent of kinase inhibition, we can see the newer drugs, so acala, zanu, tirabrutinib, have a cleaner profile than ibrutinib. So each of those circles represents a different kinase that is being inhibited. Because of course the perfect drug would simply just target the BTK. Tirabrutinib is the drug from Ono Pharma that was bought out by Celgene, but unfortunately they've not taken that forward in development, although we use that a lot in our trials program in Cambridge. So the drugs that have got through to development and now got licensed in CLL are acalabrutinib and zanubrutinib. So these are both second generation covalent BTK inhibitors. And I'll start off talking about the Elevate TN. So this is a trial we were very closely involved with in Cambridge, put a lot of patients into this study, and I'm grateful to be part of the writing committee and have seen the data coming through to publication. So older patients, included unfit patients, included those with TP53 deficiency. And these patients are randomized 3-way. So acalabrutinib or acalabrutinib plus obinutuzumab, and then the standard arm was obinutuzumab chlorambucil. With primary endpoint was the progression-free survival and a collection of secondary endpoints. So this data was updated by Jeff Sharman a couple of months ago at ASH, and this is the 6-year follow-up, and it shows this very encouraging. So 62% of patients still alive and in first remission at 6 years. So just remember, median age 70, so median age 76 really by the time we get out to this point. And you can see this is gradual smooth drop-off. At 3 years, it's about 85%, dropping to 62%. So there aren't any cliff edge effects. The blue line, that's acalabrutinib combined with obinutuzumab, and that is a very appealing regimen. We are not allowed to give that combination in our National Health Service in the UK because it has not been authorised or funded. When we look at the impact of IGHV, a great relief with these BTK inhibitors, the continuous BTK, is that the unmutated IGHV, and in this graph, that's the red solid line, and the dotted graph, which is mutated, they basically do pretty much the same. So whether or not you've got that poor prognostic marker, doesn't seem to make much difference with continuous BTK inhibition. And we've seen that with ibrutinib, acalabrutinib and zanubrutinib. And then you can see the same, adding the antibody, very little in the way of difference. Of course, with chemotherapy, you've got this big spread. So we know that unmutated IGHV CLL tends to have very short remissions when patients are treated with chemo. Likewise, another great relief is that patients with this more challenging deletion 17p or TP53 mutation, well, when they're treated with continuous BTK, we're getting quite reassuring results, 56% progression-free survival at 6 years, which is clearly very much better than the old days when patients were being treated with chemotherapy. Overall survival, well, 3/4 of these elderly patients still alive at 6 years in patients treated with acala. There was a lot of debate at ASH about this curve, and any of you who listened to the live presentation would have heard Michael Halleck from the German CLL subgroup jumping to the microphone and being amazed that that is not giving a statistical survival advantage. But as things stand, it is not statistically beneficial adding the antibody. So what about side effects? Well, thankfully, atrial fibrillation with the newer drugs is lower than it used to be with ibrutinib, and I'll show some comparative data soon, but between 7 and 9%. So this population is over 70. We tend to think of a cumulative AF rate in older people as around 1% per year. So it's probably around or a bit above background, which we have to say, because we've got 6 years follow-up in this trial now. Bleeding, so that's something we have to keep an eye on with all BTK inhibitors. Thankfully, hypertension is much less of an issue with acalabrutinib. Can I just flag second primary malignancies? Any CLL patient is more at risk of second primary malignancies, no matter how you treat them, and it's something we have to keep an eye out in our clinic. So we'll jump over to the Sequoia trial. So this is the frontline zanubrutinib trial, and I'm just showing the progression-free survivals. This is randomized zanu against bendamustine rituximab. There was some interesting stratifying here. So the 17p patients were taken out into a different trial. So perhaps this curve is a slightly better prognostic group, but we can see this similar picture. So 3.5 years, we've got 82% of patients who are in ongoing first remission. So again, very encouraging data with zanubrutinib, with a similar gradient to what we were seeing in the Elevate-TN trial. So when it comes to continuous therapy, there are some definite pros. Of course, it's the easiest if you've got your patient with you in clinic. We don't have to worry so much about the day unit and infusions and the other things that comes with some of the other therapies. It's got the big advantage that it is our most effective therapy against the poorer risk subgroups mutated in TP53. And there's something controversial, but was discussed at IWCLL, that ongoing treatment with continuous BTK inhibitors might actually select out, get rid of the more proliferative clones and leave you with a CLL that's very slow moving. And this raises the tempting question and debate about stopping BTK inhibitors. And in the UK, we're doing a big follow-up of patients who were given 6 years of ibrutinib in the FLAIR trial and then stopped. And we're seeing very little in the way of relapse rates. So it raises this very hopeful thing that actually, if you have patients who do well on long-term BTK, at some point we might have reliable data to allow us to stop them and just say to the patient, you're doing fine. Of course, in our clinics, we've all got patients who've taken BTK and stopped for whatever reason, and many have not relapsed rapidly, which is, again, encouraging. But the cons of continuous BTK, well, we have to admit, for some patients, younger, fitter people, it doesn't feel quite right putting them on a continuous ongoing therapy. And for some patients, they just don't like the concept of it. There is this potential to generate resistant mutations. So we know that mutations, particularly in the BTK molecule at the C481 locus, that's one place in particular, patients can evolve to become resistant to therapy. And of course, there's limited data on those who choose to stop. We just can't say, well, if you've done 3 years of BTK and you choose to stop, it's very hard for us to predict how long that remission will be. So that allows us to move to fixed duration. So I've covered off the continuous therapies. Fixed duration, well, venetoclax obinutuzumab or venetoclax ibrutinib are the 2 protocols that are approved worldwide. There are quite a few more coming, and we're obviously very excited about the new BTK inhibitors and how they are going to pair up with venetoclax, and some comparative data coming, but that's all hopefully to come in 2024-25. So the German trial, this is the one that got the label for venetoclax obinutuzumab. So great trial, 12 months of therapy in either arm, so 12 months of chlorambucil or 12 months of venetoclax, and they both got the obinutuzumab on the same schedule. So this is the first trial that could categorically tell us new drug versus chemo, the same type of treatment duration, is the new drug better? Now, we mustn't forget, this protocol does involve giving the infusion of obinutuzumab first, so you do have to be aware of those infusion reactions, make sure you've got a good relationship with your day unit. Tumor lysis syndrome, the dose titrations, please don't take risks and cutting that short or missing your blood test. We were all sent an advisory in the UK because there'd been deaths in Europe on the 20 milligram dose, and so we're all reminded to follow the rules. And sometimes if you've got a high risk patient, that does mean they've got to come in for inpatient care and supervision. So that's not a corner to be cut. Ottman Al-Sawaf from the German CLL team, he has updated the data regularly, and this was his ICML update last summer, so this is our current latest update. And here with, now we've got nearly, is it 7 years, 76 months of follow-up, we have a median progression-free survival here at the 76-month point. So that's a pretty decent length of remission. We can say to our patients, if you have venetoclax obinutuzumab, you've got on average a 6-year remission. However, when you look at it based on IGHV status, it clearly separates out. So after the 2-year point, you can see that these curves do separate. So the patients with unmutated IGHV, these are the ones that are falling off the curve, and the ones with mutated IGHV are more prone to keep their remission, which is very reassuring for those mutated patients. I guess with the unmutated patients, that does influence us a little bit. TP53, unfortunately, I think, although the data sets are small, most CLL doctors around the world would not rush to put patients on venetoclax obinutuzumab if they are TP53 deficient because of this ongoing relapse off the curve, and it's only a minority of patients who are still going to be in remission at 5-6 years, which is clearly quite different from continuous BTK inhibition. So how about the other fixturation trial and protocol? So ibrutinib venetoclax is now approved in many parts of the world, certainly not all. And the GLOW trial, I was very pleased to be part of the team working up on the GLOW trial on the writing group. And also I was able to present this data at the ASH conference that we've just had. So the first point to remind you of the GLOW trial, it is an older trial. Patients were quite unfit going into the study, but it was small. You can see that only 211 patients randomized because it was against chlorambucil obinutuzumab, and the statisticians rightly pointed out that with a primary endpoint of progression-free survival, we really did not need many patients to randomize to get that primary endpoint. So that was great in terms of running a trial quickly and I guess cost effectively, but not so great if you're trying to look at subgroups because it means the numbers are relatively small. And I must stress, 17 p-deleted patients were not allowed in this trial. So if we jump straight to the data that I was able to present at ASH, this shows us that 54 months out, so 4.5 years out, we've got a median, sorry, not a median, a progression-free survival of 66%. So 2/3 of the patients are alive and in remission 4.5 years out from treatment with this protocol. So just I should have reminded us that it's 3 months of ibrutinib on its own and then 12 months of the combination ibrutinib plus venetoclax. Unfortunately, we have seen, again, this ongoing relapse of the unmutated IGHV patients. And I've put the panel here. That was our 4-month follow-up that we published in Lancet Oncology. And then this is, sorry, 4-year follow-up. And then this is the approaching 5-year follow-up that we published, presented at ASH. And you can see the unmutated ones are the ones which are constantly relapsing off that curve, whereas the mutated just seem to keep their remissions ongoing. So again, yet another example where fixed duration therapies do seem to be benefiting the mutated IGHV patients. And the last point to make about the GLOW trial is about the survival kinetics. And I think it is important whenever people are talking about this protocol, in more elderly, less fit patients, there is this early mortality. And you can see how the curve pretty much before the end of the first 15 months had dropped down to 90% survival. And it took 2.5 years before the experimental arm crossed over the standard arm. Now, those early mortality events, what were they? We had 4 events were described as sudden death / cardiac. There were infections, malignancy. And I think if you're choosing I+V, you've got to ask yourself, is my patient fit enough for this regimen? There is significant neutropenia, diarrhea, hospitalization, patients stopping the treatment because of toxicities. Now, the trade-off is if you get your patient through, then you can see that we've got a relatively slow fall-off in the mortality, which is certainly encouraging. And so you will have some patients, definitely, for whom that is the correct protocol. I guess in my practice in the UK where I can use these, I'm tending to use I+V in younger, fitter patients. It is quite appealing for those with bulky disease because the tumor lysis risk is definitely reduced with that front loading of the ibrutinib. So if we move through, then fixed duration therapy, they're perfect for the right patient. It potentially keeps therapy options available for the future. And this argument about keeping the exposure period reduced for toxicity. But I think we do have to remember the patient needs to be quite committed to their treatment. They're up and down to the day. The toxicities are clearly more than individual drugs on their own. And if you haven't used these combination regimens, things like neutropenia or infection, please be aware of that. Then I+V is not approved, as it's not FDA approved in the US, and that's for a range of reasons, but around the FDA not having assessed the toxicity is what I understand. And then the other frustration is with the fixed durations, it is inescapable that the poorer genetic subgroups do seem to have this ongoing risk of relapse. So what about the current guidelines? Well, these are first-line guidelines in the US. So the US has put, these are non-17p, they've just made it simple, and they've put Acala, venetoclax, and Zanu, venetoclax plus obinutuzumab, etc., as preferred. But as I say, ibrutinib, because of its cardiac toxicity, and ibrutinib plus ven are all in other regimens. Ibrutinib plus ven has to be a category 2B because it's not FDA approved. And then, lo and behold, this is how CLL in some ways has got a bit more simple. CLL with 17p deletion, they leave all of those same options available for you there. Oral chemotherapy does get moved out, and these non-17p, you can see FCR, bendamustine, maybe that's something we discuss. In certain healthcare environments, that is still a reasonable option for specific subgroups, but ideally we wouldn't be using chemo anymore. Should we just have a quick look at what the Germans are doing? So remember, the Germans used to love separating patients out by their comorbidity status, their slow go, go, no go. I think they've basically got rid of that now, and they are grouping their patients. If you're symptomatic and you have no evidence of 17p, they then divide by mutational subgroup IGHV status. And you can see there, they're all including each option. So just like the Americans, but when I was asking Ottman about this, you can see there's this subtle nudge. If you're IGHV mutated, they're trying to encourage you to go O+V because that's their first option. And likewise, IGHV unmutated, they're putting in Acala, Zanu, they're putting in the BTK inhibitors up there first. TP53, again, they're leaning on BTK inhibition. And that's really, I think, what most of us are doing in our day-to-day practice. So I'll quickly whiz through some of the relapsed CLL stuff. I don't want to talk for too long, so we're going to have a bit of time for chat. So the exciting stuff coming through the pipeline is the trials of the new drugs against ibrutinib. So Elevate-RR, this is the acalabrutinib trial against ibrutinib. So again, another trial that we put a lot of patients into from our Cambridge trials clinic. It was quite a difficult group of patients. As you had to be 17p deleted or 11q. When we actually look at the trial data that came through, is a median 2 prior lines of therapy, so quite heavily pre-treated patients, and it had progression-free survival as an endpoint. And this is John Bird's data that's now published, and although there was this suggestion progression-free survival was favouring acalabrutinib, with longer follow-up, these curves did come together, and so there's no statistical difference, so no inferiority. And likewise with the overall survival, although the red line sits above the blue line, there is no statistical benefit. The main benefit, of course, from the new drug is really coming from adverse events. So I can just flag a few. So hypertension. In this comparative trial, it became very clear that acalabrutinib has a lower incidence of all-grade hypertension and grade 3 hypertension. Atrial fibrillation, we're seeing that now with all of the cardiac arrhythmias are much lower with the newer drugs. And here's Acala there at 9% versus 15.6% with ibrutinib. The headache, we must flag that headache is something that our patients do notice in the first month of using Acala. So if you haven't used this drug yet, when you first give it to patients, just say you can get these morning headaches. They nearly always are relatively mild, and they seem to respond to hydration, coffee, paracetamol, that type of thing. But a lot of the low-grade grumbly things like arthralgias, or the finger nail bed things, when the opportunity to try these newer drugs, and Acala in particular, it is just a bit easier to use than ibrutinib. These are the Kaplan-Meier's of the adverse events. So atrial fibrillation on the left panel, hypertension on the right panel, and you can see how the incidence of these is significantly lower with acala compared with ibrutinib, which very much matches what we're seeing in the clinic. So let's hop over to the Alpine trial. So this was the Bayesian equivalent trial, so ZANU versus ibrutinib relapsed refractory. It was different in terms of inclusion criteria. So 17p deleted patients were allowed in, but there were fewer of them in the Elevate RR trial. Had a slightly unusual primary endpoint of overall response. Well, the company were doing that, I think, to get the data out there as is possible. So I don't necessarily hold them against that. But we are now getting PFS as a secondary endpoint. And this is the data that Jennifer Brown updated a couple of months ago at ASH. So very reassuring to see that these curves are actually still apart. I guess if you're a purist, you'd say, well, look, that ibrutinib curve, progression-free survival is lagging behind. And as I mentioned early on with the Resonate trial, the ibrutinib PFS in this trial is a bit below what we have seen before. Overall survival doesn't meet significance, but again, ZANU is sitting above the ibrutinib, so second generation sat above first generation. Which is at least encouraging. But in terms of adverse events, the standout feature in comparing ZANU against ibrutinib is clearly atrial fibrillation, flutter. All the cardiac events are lower with this drug. Frustratingly, hypertension doesn't seem to be different between zanubrutinib and ibrutinib, so that seems to be where we have a bit of a signal. And we're keeping an eye on the neutropenia going forward from here with ZANU. Treatment discontinuation, so we've got around 20% of patients with this longer follow-up have stopped zanubrutinib as opposed to 26 with ibrutinib. So that is also encouraging for the new drug. This is the equivalent matched cumulative incidence of adverse events. So you can see atrial fibrillation and flutter very clearly better, but frustratingly, hypertension does seem to be pretty similar between ZANU and ibrutinib. And because I know we shouldn't be comparing trials too much, but I've put them side by side so you can see that there are consistencies between these trials. So you can see atrial fibrillation in the ibrutinib arm. Now that we've got similar follow-up, so 39 months in Alpine, 40.9 months in Elevate, and your AF rate 16%, 16%. So if anything, ZANU, perhaps, this is not statistically valid, but as objective numbers, a touch lower than acala, but you can see hypertension is much more of an issue with ZANU than acala. Neutropenia, we'll keep an eye on that. So perhaps a few more patients have stopped ZANU than acalabrutinib in the trial. So the discontinuation rate for acalabrutinib is the lowest of any. And I think that sort of supports our general clinical experience with these drugs, that perhaps acalabrutinib is the cleanest and easiest to use. But both of these newer drugs definitely much safer from a cardiac perspective. We are keeping an eye on resistance mutations, and this is a whole new field for CLL, is sequencing BTK, looking who's got the 481 mutation, who's got 528 mutations, 474. There are lots of different BTK mutations. At the moment, that doesn't necessarily matter, but going forward, of course, the new drugs like pirtobrutinib, nemtabrutinib, these different non-covalent BTKs work differently on different BTK targets. We're not yet completely sure because the data sets are only coming through as to which are the dominant resistant mutations between the different drugs, but there is a suggestion that more ZANU patients have a 528 mutation and more acala patients are closer to ibrutinib. I have a 481 mutation. So the post-ibrutinib acala looks as if it's got a bit better chance with pirtobrutinib, but that's very soft data. I don't want to overplay that at the moment. So I've just come to the very end of the talk now. So decision making in the clinic. As we all know, there are always the patient factors that influence us, the disease-specific factors and medication-specific factors. Some drugs got interactions, we've got the practicalities, we've got the simple availability. There's no point saying, I'm going to give my patient acala plus obinutuzumab if you simply have no approval for obinutuzumab. That's the challenge we have in our healthcare setting at the moment. We do our sequencing and TP53 fish with 17p deletion. I think that is standard practice if you can do it. And some groups do very formal assessments of frailty. I guess perhaps we're not as good as we could be in that regard, but whether that would help decide between drugs. So my colleagues, this is my last slide, and my colleagues say to me, oh, come on guys, CLL is sorted. Shouldn't we be putting all of our research efforts into myelodysplasia, AML, all those dreadful diseases? And I guess you can argue that, but I would point out at the moment, there are variation, pros and cons. There are still trials that need to be done. There are differences of choice we've got between different BTK inhibitors, and the advancing field, the non-covalent BTKs. I've now got 5 patients treated with pirtobrutinib and 5 patients with nemtabrutinib in my trials clinic, and it's great to see the data coming through. So I think at that point I will finish. I'll stop sharing, and I am very happy to take any questions. Thank you.
Thank you, Dr. Follis, for this wonderful talk. And now we will give a chance for questions. I have asked people on the website if they want to ask any questions, but I can't see any questions coming. So may I start with may I ask for a question, please? So actually, I have 2 questions, 2 quick ones. The first one would be, what's your thoughts on the efficacy of different BTKs? Because we don't have really strong data about which one would be more efficacious when it comes to the first line setting. I get like a little bit disappointed when I see a trial trying to compare new medicine to chlorambucil, for example. And yeah, don't you think that it's time now to do clinical trials to study not just the efficacy, but also the safety of these BTKs on the long term? What about having a trial studying the primary endpoint to be the safety? Because we can see that they are quite comparable when it comes to efficacy. You cannot really get much about which one would be more efficacious, but which one would be more safe. Let's put it this way, on the long term. And my second question, a quick one, sorry. Don't you think now it's time to think again about the indication to treat CLL? Because we used to say no need to treat an indolent disease that would not likely cause death, and patients would probably die because of something else, because they are older people already. But now the treatment is not very toxic. Why not to start it earlier than what we used to do? Thank you.
So those are great questions, because one goes to the nub of how we strategically choose our drugs, and the other goes to the really interesting thing about should we change our concept of a disease. So the first one, actually, are the trials good enough to inform us? So I agree with you that I don't think efficacy-wise you're really going to choose between the drugs. I think in terms of short-term toxicity, the more access you have to the newer drugs, so acalabrutinib, it is simply easier. It's easier for you and the patient, because a lot of, that short-term grind, whether it's diarrhea or the nail bed things or the hypertension or that, if you get AF, it does create problems with the anticoagulation. So the newer drugs are simply easier. And I think we all worry about the cardiac tox like ibrutinib. So I think I don't want to be unfair about ibrutinib, because it is a very effective drug and it has been remarkable for our patients. But if you're in a healthcare environment where you have a choice and it's equal, then you just wouldn't choose ibrutinib. But of course, you make a good comment about longer term follow-up, because there are clear gaps in our understanding. And one is our understanding about stopping the drugs. And if we're being a bit mean on our colleagues in the pharmaceutical industry, both BeiGene and AstraZeneca should have introduced a second randomization to those long-term patients in remission and randomized them to stop versus continue. And the stop arm could have restarted, because that's a great gap in our knowledge. And that might impact on long-term toxicities. Because when you talk about long-term, you've got to accept, second cancers. Who knows what the second cancer rate is at 10 years, 15 years? Long-term other things that it's hard to predict. So I think, that's my view on that. I'm not sure the trials have been done that are going to inform us. And I think no one's going to run an acala versus Zanu trial, because nobody's interested to do it. So the pharma industry is not going to fund that one. So that's a long rambling answer to your first question. The second one, I actually like that question more than ever because we're faced with that. I'll give you an example. In my clinic yesterday, I've got a patient with a sort of Waldenstrom's with an IgM paraprotein of 20 grams. He's previously had some rituximab. He's not that unwell, but the lethargy is really impacting on his day-to-day. He's just sort of lethargic, feels a bit rubbish. And I know we can just pop him on zanubrutinib. And in the same way with CLL, all of us in our clinics have got those early stage patients who are just feeling a bit rubbish. And we know that they're going to have a normal life expectancy. And according to IWCLL, they're not symptomatic enough. We're not going to treat them. We're not going to change their natural history. So we don't start them. So there's quite a few people who are just suffering from a sort of low grade grumble. And we know if you pop that type of patient on acalabrutinib, or that Waldenstrom's one went on zanubrutinib, there's a good chance 3 months from now they'd simply feel much better. But none of us want to advocate treating the asymptomatic patient because the trials when it has been done, so like the German trial that was just updated, CLL12 from memory, has not shown any clear advantage for early intervention. But your point is, as the drugs get better, that's when surely interventions might be better. Because if you have no side effects, and imagine if you could start someone on a CLL drug and then their immune system wouldn't fall apart. They wouldn't get the autoimmune problems. They wouldn't get the lethargy. Then it would be a no-brainer, presumably, if the drug was clean enough. I'm not quite sure we're there yet, but I do like the concept. I do like the concept.
Thank you for your excellent presentation. My question is, where do monoclonals fit in all of this example of therapy in CLL?
Was that, where does chemotherapy sit in all of this? Sorry.
There's a comment by one of my colleagues about the chemotherapy. And my comment is on the immune therapy, first or second generation immune therapy, namely monoclonal antibodies.
Yeah, I do apologize. It's my computer here.
Rituximab and the alike.
Oh, so the rituximab and obinutuzumab is a good question, and the German CLL13 trial, which I didn't present, gives us another insight into the difference in CLL. So we all know in follicular lymphoma that obinutuzumab and rituximab, you know, Roche, Genentech, they really struggled to convince us that there was a big difference. And I must say, in our practice in follicular lymphoma, we still just use rituximab, bendamustine, and R-CHOP. We haven't been hugely convinced. But in CLL, the obinutuzumab data compared with rituximab in the CLL11 trial and now the CLL13 trial has been quite convincing. And I think that's the strongest argument that, number one, the antibody does something, and number two, that obinutuzumab is better than rituximab. Now, your colleague's question, I noticed that chemo is not mentioned at all in the first-line setting that he's put in. And this is a difficult area because all of us in our clinics have people who we gave chemotherapy to 10 years ago and they're absolutely fine. I've got people who send me emails from random bits of the world who I gave chemo to 10 years ago. They've now moved to Australia, Canada. I've got one guy in Scotland. And if I'd given them ongoing treatment at the time, you know, they'd still be committed to treatment potentially, and yet they had their chemo and they're fine. The challenge we have with chemotherapy is all about balancing statistical risks. So what is the chance that patient gets septic, gets admitted, gets a damaged bone marrow, gets secondary leukemia? And all of those are definite risks. But if you are in a healthcare environment where you don't necessarily have the same access to drugs, and you have a patient with IGHV mutated CLL, well, we all know that bendamustine, rituximab, FCR, they can put patients into remissions that might never need another treatment. So for some patients, it is still fine. If they had an unmutated IGHV, definitely if they have TP53 dysfunction, then giving that type of patient chemo would be a shame. But the reason I've moved it out of my decks is because Venetoclax obinutuzumab, if you can imagine that patient that you really would like to have given chemo to in the past, then venetoclax obinutuzumab has been validated in CLL14 and now CLL13. So if you want to give someone fixed duration treatment, you can give them Veno. Hopefully that answers the question.
So yeah, I think by that we would conclude. I would like to thank you, Dr. George, for this wonderful talk and for your time and for the discussion afterwards. And we hope to see you again soon, hopefully in our next JSH conference. Thank you.
Thank you very much for the invitation. It's been my pleasure to take part. Thank you.
Thank you.
Hi, Dr. Trudel, how are you?
Very well, thank you.
This is Rosen. If you remember me, I was doing the fellowship at Canada. It's my great pleasure to present you today and to meet you today. Thank you for your presence and thank you for everything. Thank you for accepting our invitation, and it's my pleasure again to introduce you. Dr. Trudel received her MD degree from the Faculty of Medicine at the University of Toronto, and subsequently completed the subspecialty training in hematology at the University of Toronto Affiliated Hospital. This was followed by a research fellowship at Well Medical College of Cornell in New York. Dr. Trudel returned to Toronto as a consultant in the Department of Medical Oncology and Hematology at the Migrant Cancer Center and is currently appointed as a professor degree. Dr. Trudel has served on the steering committee of multiple myeloma research, MMRC. She is a member of the Myeloma Canada Advisory Board and International Myeloma Working Group. She is a previous member of ad hoc scientific committee on plasma cell biology for the American Society of Hematology. Dr. Trudel is appointed as special expert member of the National Cancer Institute Myeloma Steering Committee. She is a principal investigator on numerous clinical trials for relapse myeloma, and her work has been published in numerous reference journals, including Nature Medicine, Lancet Oncology, Nature Communications, the Journal of Clinical Oncology, and Blood. So now talks is your Dr. Trudel.
Okay, let me try to get my slides uploaded here. Can you see my slides?
No.
No? Try again.
You can use the share slides.
Yeah. Okay, for some reason my computer is not letting me share. Let me just see what's going on here. Screen record. Do you have my slides there that you can show? Let me see.
Yes, we have them. We'll try to just
Do you have them up? Oh yeah, I see them there, right? Everybody can see my slides?
Yes.
Okay, how am I going to move them forward?
Next. So you're still on next. Yes, just tell us next.
Okay. I would really like to thank you for the invitation to present at your annual meeting. It is my tremendous disappointment that I cannot be with you in person. I have to say that we do have many trainees who come from Jordan, and when they share photos with us, they're spectacular, and you have a beautiful country. So I hope one day to be able to visit. So my presentation is going to be on advances in multiple myeloma with a focus on what used to be an unmet need, the late relapse, and now what is the current unmet need in early relapse disease. So these are my disclosures. You can move on to the next slide. So as mentioned, advances that have been made in the treatment of triple class exposed and refractory disease have been transformative, such that this disease may no longer, or this stage of the disease, I should say, may no longer be an unmet medical need. Next slide. So this is historical data to show you the outcomes of these patients prior to the introduction of new drugs into the relapse refractory myeloma setting. So this is data from the locomotion study that enrolled 248 patients that were triple class exposed. You see the majority of patients are triple class refractory. And these patients were treated with standard of care agents prior to the era of anti-BCMA therapy. And we see that the outcomes are quite dismal, with an overall response rate of around 30%, median progression-free survival of 4.6 months, and an overall survival of a year. So this really highlights the need for development of new drugs in this patient setting, and also serves as a benchmark for the evaluation of new treatments in patients that are triple class exposed and refractory. Next slide. So the armamentarium of multiple myeloma therapy has really been progressing at breakneck speed, and the last few years have seen the approval of a new class of drugs targeting BCMA, and this now represents the fourth pillar of myeloma therapy for relapse refractory disease. Next slide. So first, starting with belantamab mafodotin, which I will refer to as belamaf. This is a humanized afucosylated IgG1 BCMA-targeted antibody drug conjugate that is tethered through a non-cleavable link to a microtubule inhibitor, MMAF. Now, it eliminates myeloma cells by multiple mechanisms of action, including immune-dependent mechanisms, and that's brought on by the afucosylated of the FC receptor, which enhances its ability to recruit and activate immune effector cells, inducing ADCC and ADCP. In addition, preclinical studies have demonstrated that it induces immunogenic cell death. And it also has non-immune independent mechanisms, which really differentiates it from other BCMA targeting agents such as CAR-Ts and bispecifics in its ability to induce direct cell kill via microtubular polymerization. Next slide. So belamaf was approved, or conditionally approved, I should say, by the FDA and the EMA based on the results of the DREAM2 study, which enrolled patients that were triple class refractory. 100% of patients were triple class refractory and had received 7 prior lines of therapy. And for those patients treated with the 2.5 mg/kg dose administered every 3 weeks, which was the dose selected to move forward, the overall response rate was 31%. And reflective of the modest overall response rate, the median progression-free survival was only 2.8 months. However, what we do see, and I think is quite important, is that for those patients who achieved a response, these were durable, with a median duration of response of 12.5 months. And for those patients, even those patients who just achieved a minimal response, the overall survival was not yet reached with the more recent follow-up of 12.5 months. Now, as far as the safety profile, the most commonly reported adverse events are consistent with those that we would expect for MMAF-containing ADCs, and were primarily keratopathy, which I will speak to further in the next slide, and thrombocytopenia. So corneal events, as mentioned, are commonly reported with MMAF immunoconjugates and are characterized by, as you see here, deposits and microcysts that are seen in the cornea on slit lamp exam. This was reported in 72% of patients in the DREAM2 study and is commonly associated with symptoms of blurred vision and dry eye. And we see that symptoms related to belamaf, eye symptoms were reported in 56% of patients. Only 18% of patients had significant decrease in visual acuity to 20 or 50 or less, and only 3% of patients discontinued treatment for corneal events. Next. So the corneal events are mitigated by dose holds until the corneal events recover, and dose reductions, and therefore they require baseline eye exams and eye exams prior to each dose, as well as the use of preservative-free artificial tears and for the duration of treatment. Now, an ad hoc analysis from the DREAM2 study revealed that for patients who were responding, despite a prolonged dose holds of 9 weeks or more for corneal toxicities, those patients, actually 88% of the patients, continued to maintain their clinical benefit, and in fact 38% of patients actually deepened their response. So this has led to the idea that perhaps we can extend the dosing of belamaf, not give it every 3 weeks, and therefore mitigate some of the corneal toxicities. And this is being explored in a number of studies and appears to be beneficial. Next slide. Now, unfortunately, belamaf was withdrawn from the European and US markets based on the results of the DREAM3 study, which was a comparative study of single-agent belamaf versus the doublet of pomalidomide and dexamethasone. And although the progression-free survival was 11.2 months for belamaf versus 7 months for PomDex, this did not meet statistical significance for superior PFS. But importantly, if we look at the Kaplan-Meier curves, what you see is that there is a crossover, and that for those, and that we see that the PFS actually becomes superior and maintains a superiority over PD after the 3-4 month crossover. And I think more importantly, we see that the median duration of response is the curves separate and is not even reached at the time of this analysis. So this durability of response that is seen with belamaf is reported across all the DREAM trials and is thought to be related to the ability of belamaf to induce immunogenic cell death. It would therefore seem logical that if we combine belamaf with other anti-myeloma agents, we can prevent this early progression and allow patients to benefit for the improvement in duration of response. And this, as you will see, has been the case for the DREAM7 and the Algonquin study that I will present later in this presentation. Next slide. So CARTITUDE-1 was a study that evaluated the BCMA targeted CAR T cell product, cilta-cel. And the results of the CARTITUDE-1 study are really unprecedented. Again, it was evaluated in patients that were triple class exposed, the majority of patients triple class refractory, having received a median of 6 prior lines of therapy. And we see a remarkable overall response rate of 98%, with a median progression-free survival of 34.9 months and 62.9% of patients remaining alive at 36 months. The most commonly reported adverse events with cilta-cel are consistent with what we would expect with CAR T, CRS, neurotoxicity, cytopenias, infection. Of note, however, there has been a signal and now a box warning for secondary malignancies with CAR T cell products. In addition, there have been reports of late neurotoxicities with this product. Next slide. So teclistamab is a bispecific antibody that binds simultaneously to BCMA on myeloma cells and CD3 on T cells, allowing for T cell redirected killing of BCMA expressing cells. And it was evaluated in the MajesTEC-1 study. 165 patients were triple class exposed. A majority, again, triple class refractory, were enrolled in the study and received the recommended part 2 dose of 1.5 mg per kg weekly. We see, again, very impressive results with teclistamab with an overall response rate of 63%, a median PFS of 11.3 months, and a median duration of response of 21.6 months. The most commonly reported adverse events are consistent with what we would expect with bispecifics, with CRS, mostly low grade, and neutropenia being the most commonly reported toxicities. Neurotoxicity was rare and almost exclusively grade 1 and 2. But what has come out as an important signal is infection. We see 80% of patients experiencing infection, 52% grade 3 or 4. And in fact, there were 21 deaths due to infection, 18 due to COVID-19. Next slide. So this table summarizes key data from other notable bispecifics targeting BCMA. We see that these vary in their dosing modalities, sub-Q and some are IV, as well as their schedule. Some are weekly and some are every 3 weeks. Almost all the studies enroll patients over the age of 80. The median prior lines of therapy range from 4 to 6, so heavily pretreated patients, with the majority of patients on the studies being triple class refractory. We see very encouraging overall response rates ranging from 61% to 68% with these products. Data on durability of responses is somewhat immature, but for those that are reporting, they look quite promising. The safety profile, again, is consistent with that we would expect with bispecifics, with CRS being the most commonly, and neutropenia being the most commonly reported adverse events, CRS primarily being low grade, neurotoxicity being relatively rare and low grade as well. But again, we see that the majority of these studies show a high rate of high grade infections, and really highlights the needs for comprehensive strategies to reduce the risk of infections. And certainly we're exploring now more dosing schedules that are extended or finite periods of treatment to reduce the risk of infection, as well as the use of growth factor supports, prophylaxis for virus and bacteria, and the use of IVIG, which you'll see in the next slide. This is data from Dr. Lankman from our institution, where you can clearly see that when patients receive IVIG, that there is a marked reduction in grade 3-5 infections, both overall infections and bacterial infections. Next slide. So the antibody therapies or immune therapies targeting CD38, SLAM-F7, and now BCMA have really been transformative for the treatment of multiple myeloma, and have really urged on the development of immune therapies targeting established and novel antigens. Next slide. With the most promising being FcRH5 and GPRC5D. Next slide. So talquetamab is a bispecific that targets CD3 and GPRC5D, and you can see that the expression is most restricted to keratinized tissue skin, which will, as you will see, influence its safety profile, as well as plasma cells. Now, interestingly, the expression of GPRC5D is highest in myeloma cells, even higher than that of normal plasma cells. And this has been theorized as the reason why we see perhaps less hypogammaglobulinemia and infection with talquetamab. Next slide. So this is the results of the monumental study, which is the first in human study looking at talquetamab. It explored 2 doses of talquetamab, 405 mg per kg every week and 800 mg per kg every 2 weeks, with the 800 mg per kg every 2 weeks being selected for further evaluation. We see that, again, these enrolled patients that were triple class exposed, the majority triple class refractory, having received 5 prior lines of therapy. And the overall response rate for the 800 mg per kg every 2 weeks was impressive at 71.7%, with the median duration of response of 11 months and a median progression-free survival of 12 months. Again, the safety profile here consistent with what we expect with bispecifics, high incidence of CRS, mostly low grade, and neutropenia. However, importantly, what we see is that the grade 3-4 infection rate is lower at 14% with this product. And we see also on-target off-tumor toxicities with among the most commonly reported adverse events, skin-related AEs, as well as nail AEs and dysgeusia. Next slide. And this here gives you an example of the toxicities we see in these patients: rash, peeling skin, the nail changes. And these are primarily treated with emollient creams and as well as dose holds. Next slide. And now there has been a CAR T-cell product that targets GPRC5D. Results were recently published in the New England Journal of Medicine. Again, this enrolled patients who were triple class exposed, and a number of patients had received prior anti-BCMA therapy. We see that in 16 patients, almost all patients responded to this CAR T-cell product, and for some patients, the responses appear to be durable, and the toxicity profile is consistent with that of CAR T-cells, and we see that similarly, we see nail changes, skin changes, and dysgeusia, although the rates appear to be lower than what you see with talquetamab. Next slide. So cevostamab is a bispecific that targets FcRH5 on plasma cells and CD3 on T cells. FcRH5 is exclusively expressed. Now, it is expressed across the B cell lineage. However, the highest expression is on normal plasma cells and malignant plasma cells. Next slide. So at ASH several years ago, we presented the first in-human data of cevostamab, exploring doses ranging from 20 to 198 milligrams every 3 weeks, IV, with a finite number of 17 cycles. Again, the majority of patients were triple-class refractory, and a third of the patients had had prior anti-BCMA therapy. The overall response rate across all the dosing cohorts was 45%. But we noticed that the patients who received higher doses, 132 to 198 milligrams, had an overall response rate that was higher at 56.7%. The safety profile is consistent with what we would expect with bispecifics, and there were no off-tumor toxicities reported. Next slide. So we have explored the use of the anti-IL-6 tocilizumab as pretreatment prior to cevostamab administration to reduce the risk of CRS. And we see here that indeed the CRS rate was 38.7% for patients who received pretreatment with tocilizumab, compared to 90% for those who did not receive tocilizumab pretreatment. And importantly, this did not have a negative impact on response rate. The response rate was 54.8% for those who received toci pretreatment, and 37.2% for those who did not receive toci pretreatment. So this appears to be a strategy that may be able to mitigate CRS and allow for outpatient administration of bispecifics, as this data has also been reproduced by those looking at tocilizumab pretreatment prior to teclistamab. Next slide. So a number of putative mechanisms of resistance have been proposed for bispecifics, and they include tumor-related factors such as loss of antigen or mutations of antigens that prevent bispecific binding, in addition to those that are immune-related and an immunosuppressive tumor environment. Next slide. So this now allows for a scientific rationale. That's next slide. Sorry, go back. Yeah, thank you. Sorry, no, back again. A scientific rationale for combination strategies with bispecifics, including the use of anti-CD38s, which will eliminate Tregs and increase T cell numbers and activity, as well as IMiDs, which activate T cells. Next slide. And indeed, the combinations with teclistamab with daratumumab, or teclistamab with lenalidomide and daratumumab, as you can see, show overall response rates that are higher than that of teclistamab as a single agent reported in the in the Majestics 1 study, so 63% versus 76.7% with the addition of DARA, and 93.5% with the addition of lenalidomide and daratumumab. Next slide. Similarly, we see that with the addition of daratumumab to talquetamab, the response rates are 84% compared to single agent talquetamab from the Monumenta 1 study of 69%. And I think very impressively, data presented at ASCO is a combination of talquetamab and teclistamab, which showed an overall response rate of 96.3%. Next slide. So there has been evolution in cereblon binding agents beyond thalidomide, lenalidomide, and pomalidomide to now include iberdomide and mezigdomide. Those similarly bind to cereblon and enhance its ability of the cerebron substrate to bind to neosubstrates, in particular IRF4, leading to its ubiquination and degradation. Next slide. So iberdomide and dexamethasone was evaluated in a phase 1/2 study in the intent to treat patient population of 107 patients. The overall response rate in patients that were triple class exposed, mostly triple class refractory, was 26.2%, noting that these responses were maintained even in patients that were BCMA exposed at 25%, and the median duration of response was 7 months, and the safety profile is consistent with what we would expect with IMiDs. We primarily see cytopenias with this agent. Next slide. Now, mezigdomide and dexamethasone, we recently published in the New England Journal of Medicine this data. Again, heavily pretreated patients, 100% triple class refractory, 30% having had prior anti-BCMA therapy. At the dose expansion, a dose of 1 mg day 1 to 21, dexamethasone 40 milligrams weekly, we see an overall response rate of 40.6%, and 50% for those patients who had prior anti-BCMA with a median PFS of 4.4 months. Here we see that this agent induces more neutropenia with a neutropenia rate of 76% compared to iberdomide and the other IMiDs, and 32% of patients did require dose reductions. Next slide. So both iberdomide and mezigdomide are now being evaluated in combination with other anti-myeloma agents in newly diagnosed and early relapse setting. We're waiting the data from these studies. Next slide. So to summarize this first part of my talk, BCMA-targeted therapies represent the fourth pillar of myeloma therapy, with CAR T-cell products, cilta-cel, demonstrating unprecedented overall response rate and PFS in this patient population that had previously been of high unmet need. Immunotherapies beyond CAR T have emerged as an important off-the-shelf option for relapse refractory myeloma. They include ADCs that are fully outpatient administration with no risk of CRS or increased risk of infection, but are challenging with corneal toxicities, and the data currently does not support their use as a single agent. Bispecifics have demonstrated impressive single-agent activity in heavily pretreated myeloma, including those with alternative targets to BCMA. Infections, however, are the Achilles heel. Will longer dosing interval and discontinuation of therapy mitigate this risk? And certainly IVIG appears to be beneficial. And finally, CELMoDs are showing promising activity with potential for combination therapy with standard of care myeloma agents and investigational agents. Next slide. So I'd like to mention now that really the new unmet need in myeloma may actually be in the early relapse setting, and how anti-BCMA targeted agents may be of use in this patient population. Next slide. So the earlier use of lenalidomide and now the growing use of anti-CD38 monoclonal antibodies in newly diagnosed patients, both transplant eligible and ineligible, means that a majority of patients that relapse will now be DARA and len refractory and in need of novel combinations in second line. Next. So the CARTITUDE-4 study is a phase 3 study that compared cilta-cel to standard of care agents, pomalidomide, Velcade, and dexamethasone, or daratumumab, pomalidomide, and dexamethasone. We see here that this is in the early relapse setting with a median prior lines of therapy of 2. And showing you how high the unmet need now is in this early relapse patient population with standard of care agents, the median progression-free survival was only 11.8 months for those patients who receive PVD or DPD. However, for those patients who receive cilta-cel, the median progression-free survival was quite impressive and not yet being reached. Suggesting that this may be now a new standard of care for early relapse patients. Next slide. Similarly, the CAR T-cell product targeting BCMA, ide-cel, was evaluated in the KarMMa-3 study and compared to standard of care agents that included Dara-PD, Dara-VD, Ixazomib, Lendex, Carfilzomib, Dex, Elotuzumab PD at the investigator's choice. Patients here had received a median of 3 prior lines of therapy. And again, you can see how high the unmet need now is in this early relapse patient population, because with these various standard of care regimens, the median progression-free survival was only 4.4 months. But we see that it is statistically better for those patients who received ide-cel with a median PFS of 13.3 months and a hazard ratio of 0.49. Next slide. Now, the bispecifics are also moving into the earlier line setting, and this is one of the arms from the MajesTEC-2 study that added daratumumab and lenalidomide to teclistamab. Again, this was in patients who'd received 1 to 3 prior lines of therapy. We see a very impressive overall response rate of 90.6 months. However, overall response rate, I should say, of 93.5%. However, I'd like to caution here the incidence of infection was very high, 90.6%, with a very high risk of infection, grade 3/4 at 37.5%, with a very short follow-up. So we expect that the rate of grade 3/4 infection will continue to increase as this is a cumulative toxicity. So it is yet to be determined what the feasibility is of combining bispecifics, or particularly BCMA bispecifics, with daratumumab and lenalidomide because of the challenges of infection. Next slide. So more recently, the results of the DREAM-7 have been released. This was a phase 3 study that compared belamaf with bortezomib and dexamethasone head-to-head with daratumumab, bortezomib, and dexamethasone. And we see here that the results are quite impressive in the favor of an anti-BCMA with bortezomib, dexamethasone. The overall response rate was 82.7% compared to for Bela-VD versus 71.3% for Dara-VD. But more impressive, you can see the median progression-free survival was 36.6 months for Bela-VD compared to 13.4 months for Dara-VD, with an overall survival that is yet somewhat immature, but trending towards a survival benefit with a hazard ratio of 0.57. Next slide. So we have evaluated the combination of belamaf with pomalidomide and dexamethasone in the Algonquin study, which is a 2-part study to determine the recommended part 2 dose and then evaluate the overall response rate at the recommended part 2 dose. We explored a number of different dosing schedules, 1.92 to 3.4 mg per kg, and doses and dosing schedules ranging from every 4 weeks, 8 weeks, and 12-week administration. And we reported that the maximum tolerated dose was 2.5 mg per kg in combination with standard dosing of pomalidomide and dexamethasone. And the recommended part 2 dose was 2.5 mg per kg administered every 8 weeks, as we found that this reduced the risk of corneal toxicities. Next slide. So we recently published the data in Nature Medicine. And we see that at the recommended part 2 dose for 34 patients who were response evaluable, the response rate was quite high at 3%, noting that this was a patient population that had received 3 prior lines of therapy, and the majority of patients were triple-class refractory. The median progression-free survival and overall survival had not been reached at the time of our analysis, which was a follow-up of 13.9 months. And that the estimated 2-year progression-free survival was 52.8% at that median follow-up. And as mentioned earlier, we found that with a Q8-week schedule versus a Q4-week schedule, there was a reduction in the incidence of grade 3/4 keratopathy and decreased corrected visual acuity. Next slide. So this is my final slide summarizing this part of the treatment of the presentation. So with the Maya and Griffin regimens being increasingly used in first line, patients in first relapse or second line will need a LAN anti-CD38 sparing option. And currently our approved and available options really show progression-free survivals that are very limited, and this patient population really represents an unmet medical need. BCMA-based regimens are a promising approach due to the efficacy demonstrated by these agents as monotherapy in the relapse refractory setting, as I presented earlier in my talk, and preliminary results with anti-BCMA therapy combination regimens in the early relapse setting demonstrate encouraging efficacy. Next slide. Oh, sorry, that's the end of my talk. So my last slide I was not included in this presentation, but it was a thank you, and I was going to show you our team at Princess Margaret that some of you may be familiar with. Thank you for your attention.
Thank you, Dr. for your presentation. I have my question about BCMA targeted agent and CRS. Okay, can we use tocilizumab as a prophylactic to prevent CRS in CAR-T agents, or if we use BCMA agents? Can we use tocilizumab, interleukin-6 antagonist?
Yeah, so
yeah.
just let me, because it's a little bit hard to hear questions, but just what I'm hearing from you is, can we use tocilizumab to prevent CRS with bispecifics? Is that correct?
Yeah.
Yeah. So yes, our data would suggest that the rate of CRS is decreased by about 60% if you use tocilizumab prior to cevostamab, and similar data, almost identical, were recently presented and published using tocilizumab prior to teclistamab. So it's very consistent that yes, we see a marked reduction in CRS when we use tocilizumab prior to bispecifics, and we do not, the concern was, do we compromise efficacy? And it does not appear that the efficacy is compromised. So this, I think, can help facilitate outpatient administration. The only problem we have is we still cannot predict that, 30% or so of patients who will get CRS. So there's still the challenge that we don't completely eliminate CRS. And so I think if you're going to do this to allow for outpatient administration, patients will still need to be close to the facility, and you will have to be able to admit patients if they do develop fever, CRS, if they're getting outpatient administration, although the number of patients should be lower.
Thank you, Dr. Trudeau, for your this excellent presentation. First, my comment about betamab. I think even if it is withdrawn from the market, but the future for betamab is the combination of betamab, especially with the immunomodulators, as was shown in the ongoing Queen trial. So my question here regarding the CAR T cell and the development of new cases, despite they are very rare cases, of T cell lymphoma. So how can we explain the development of such lymphoma post-CAR T cell? The other question about the most proper sequences of those anti-BCMA, if we have all of them available, what would be the first option of us to give for fast refractory? And the last question regarding the outcome of extramedullary disease. As we know, they are very high-risk patients and with a low response, even with the anti-BCMA. So what would be the best approach for those patients? Thank you.
Thank you. All excellent questions. And I think you're correct about the CAR-Ts. Now there has been a box warning that about the secondary malignancies, and particularly the secondary lymphomas. I'm not sure that we exactly know why, but I think it's thought to perhaps be due to the integration of the lentivirus within the T cells that are reinfused that are causing these. So perhaps I'm not sure if the data using different methods for transduction of the CAR-T will lead to lower risks of these types of T-cell lymphomas. I think that data will have to come. For the second question the second question was with regards to sequencing of BCMA targeted agents, right? So I didn't put that slide in my talk just because I wasn't sure how much time I would have, but certainly there is growing data to help us with trying to understand how to sequence these agents. So what the data suggests currently is that if you use a bispecific or an ADC prior to a CAR T-cell product, that you may compromise the efficacy of the CAR T-cell. So responses, for example, with cilta-cel in the one of their studies, they showed that the overall response rate was around 60% for patients who had bispecifics or ADCs prior to cilta-cel, compared to 90% over 90% for patients who were anti-BCMA naive, and the progression-free survival was also much shorter. Whereas with bispecifics, the data that's emerging with bispecifics is that there is just a very modest reduction in efficacy if you use a CAR T-cell or an ADC prior to a bispecific. So I think that data, at least at this point in time, while we wait for more evidence, would suggest that you should use your CAR T-cell first, because that's where you're going to see your biggest bang for the buck. And then subsequently, you can use your bispecific and your ADC without really compromising too much the activity. So for now, I think that should be the order in which to use them. Of course, you will have patients that just cannot wait for CAR-T. As we saw from the cilta-cel study, about 15% of patients progressed before receiving the CAR T-cell product. So in those patients, you have to go with a bispecific, an off-the-shelf product to benefit those patients. But if you have the luxury of time and the patient is slowly progressing, I would use the CAR T-cell first. And then the third question was on
Extramedullary disease.
Oh, extramedullary disease. Yeah, so you're exactly right there. So if you look at the data for both CAR T cells and bispecifics, the patient populations that tend not to obtain as much a benefit are the patients who have extramedullary disease, the patients who have heavy disease burden, so high bone marrow percentage, over 60%, and those that are ISS stage 3. Those patients do not do as well either with CAR T or with bispecific. So they really represent the remaining high unmet need. I think the best data so far for those patients comes from the combination of talquetamab and teclistamab, which showed a high response rate and some durability to responses. There is a trial ongoing, which we are enrolling patients at our center with this combination specifically for extramedullary disease. And so far, what we've seen is very encouraging data.
Thank you very much.
Thank you, Dr. Charlie. There is a question for Dr. Mohammed Salame. When do you think start using CAR T cell upfront therapy?
So
when do you think to start using CAR T cell in upfront therapy?
In upfront therapy. Well, I think we have to wait for the data on that. So unless we sort of see that there's a benefit to CAR T compared to stem cell transplant or to standard of care. In the non-transplant eligible patients, we will not be using CAR T cell therapy off trial in the newly diagnosed. We're hoping that data will be coming. There's certainly there's a CARTITUDE-5 study that compared CAR T cell to RVD for in the non-transplant eligible patients. And then there's the CARTITUDE-6 study, which is comparing essentially the Griffin type protocol to patients getting a CAR T instead after getting DARA RVD induction. So those studies will be informative and to us making decisions about using CAR T upfront. But as you know, in newly diagnosed myeloma patients, it takes a very long time to get PFS readout. So we're hoping that we'll be able to use MRD as the endpoint to help us inform us. Otherwise, it will be a while before we can use CAR T in frontline.
Thank you, Doctor. There is other question for Dr. Mohammed Salame. In case of plasma cell leukemia, is there any role for CAR T?
Yeah, I think that's a very interesting question. I mean, we know plasma cell leukemia is very challenging. And I don't think we have any data on the outcomes of patients with plasma cell leukemia with CAR T cell. As you know, these patients would have been excluded from the clinical trials. And I think that data will have to come from essentially real world experience, people using it, for example, in the US or Europe for these patients, but the number of plasma cell leukemia are very low, as you know, and it'll take time for us to actually see data in this patient population. It's very sad that these patients are excluded for clinical trials.
Thank you, Dr. Mohammed.
Yes, thank you for your excellent presentation. My question is a little bit not exactly on the topic, is on smoldering high-risk multiple myeloma. Where do we stand today?
Yeah, you have Mary V talking to you tomorrow, so I would really ask Mary V her opinion because the two of us probably differ a little bit where that's concerned. So we know that, you know, there are studies published, the Spanish study that Mary V has published that suggests that treating with lenalidomide and dexamethasone improved the PFS compared to no treatment for the high-risk myeloma patients. But we know that there were issues with that study. The patients that were enrolled were almost pretty much myeloma patients. And although they show an overall survival benefit, the study wasn't really powered for that. There was a subsequent study from the US also suggesting that Lendex may be of benefit in the smoldering patient population. I think some of us are a little bit skeptical still at this point in time that that is the appropriate way forward. You know, really, we need survival benefit when we're talking about smoldering myeloma patients, that there are downsides to treatment with toxicities. So, you know, I think at this point in time, it really will depend on who you talk to, their opinion on it, and how they interpret the studies.
Well, I think there is no more question. We would like to thank you very much, Dr. Trudel, for your kind acceptance of our invitation, and hope we will see you again and again in our meetings. Thank you very much.
Well, thank you so much. It was wonderful questions, and I wish you guys a great rest of the meeting.
Thank you.
Bye.
Right. Good day,
Good evening, everybody. Now we have a talk for Dr. Khalid Christopher Gilani, who is a professor at the hematology at Aalborg University Hospital in Denmark. And his main clinical interest in lymphomas, and in particular the aggressive lymphomas. And his main research focuses on the use of real-world data and registers to inform clinical practice. Dr. Gilani is chair of the National Ethics Committee for Device Medicine Studies, as well as vice chair for the Scientific Device Advice, the group of hematology oncology at the EMA. Okay, please, Dr. Al-Gilani.
Thank you very much. Do you hear me?
Please join us to welcome Dr. Al-Gilani. He will be talking about real-world evidence in lymphoma potentials and pitfalls.
Thank you very much. Do you hear me?
Yes.
Good. I'll try to share my screen.
We can
So
see.
you can see my screen. You see my PowerPoint, right?
Yes.
Great. So thank you so much for this invitation. I represent also the European Hematology Association. This is a collaboration, and I'm very honored to be able to give this talk to you. I wish I could have been there, but unfortunately this was not possible. Okay. So this is my disclosures. I have no disclosures the past 24 months, and I'll also be showing some unpublished data, so please don't share this on social media. So what I want to talk to you about today is use of real-world data, the definitions and types of data sources, and then specifically address the use of real-world data for comparative effectiveness studies. What are the pitfalls, potentials, possibilities? I will say that this talk is going to have lymphoma in focus in the examples, most of the examples, but it's actually more a conceptual talk, and I think it applies to cancer research in general. So what is real-world data? We have so many sources that we can call real-world data today. We have the normal registries that many of us, especially in Europe and especially in the Nordic countries, use quite a lot. We also have opportunities to go to medical files, like the electronic health records. This is also an option and type of real-world data. This is what we typically know. We have also opportunities to collect information directly from patients, from iPads, iPhones, and we have social media, which is also increasingly used in medicine. We have quality of life data, and we have, of course, all the data from biobanks around the world, which is also type of real-world data. So we have so many data sources today, but really, then what is the definition on real-world data? How do we define real-world data, the data that is not generated in trials? There was a study looking at this published some years ago, and what was really interesting was that there was really no standard definition on real-world data. So this was a literature review and expert interview, and they identified 38 different definitions. So it's very important, first of all, when we talk about real-world data, to define what we're actually talking about. But this study defined 4 different categories. They were able to categorize most of the answers into these 4 categories. Some feels that data collected outside a randomized trial, everything that is outside a randomized trial is real-world data. Some said that it's data collected outside an intervention or controlled setting, and some said it's data collected outside an experimental setting. This means no de novo data collection. All data is reused or collected for some other purpose and then reused for a specific real-world data studies. And these definitions really matter when we discuss the applicability of real-world data. So if you look at it from that aspect, you can have a continuum of different kinds of data. The highest grade evidence from the randomized trials, the lowest grade maybe from the non-experimental setting. If we define real-world data as everything coming out of non-randomized settings, then we really have a lot of options, and we really have also very high quality data. We have single-arm trials, we have non-interventional trials, If we are more conservative and say it's only the non-experimental data, then we are talking about data not collected for a specific study, and we have all the issues of bias, missingness, and so on. If you look at how the FDA defines real data, they define it as data regarding the uses or the potential benefit of risk of a drug derived from sources other than traditional clinical trials. And this is also how I prefer to define this. So everything that is not from a clinical trial. What's really important is that many will think that when you talk about real world data and real world data studies, this is also always retrospective studies, and this is also often the case, but it's quite important to remember that many of these data were actually collected prospectively and not specifically for the study in mind. This means also that some of the bias that there may be is maybe not present because data were actually registered and collected before you were interested in a specific outcome. But of course, the analysis is done retrospectively. So for many years, real world data has been an interest for academia. So for many academic groups in the Nordics, especially because of our registries, this has been our main interest to see how we can use registries and real world data to inform clinical practice. But I think now it's becoming quite clear that many more are interested in this, because industry is also showing increasing interest in use of data that are not in their possession, that are collected in our clinical practice. This is because of opportunities to maybe run faster trials. If you can run hybrid trials where you have partially control arms from a real world data setting, it would give lower costs. It's also used for reimbursement issues. We have often a request to document outcomes of clinical practice in, for example, Denmark before anything is reimbursed, or what is the typical clinical practice. I also think regulators are showing an increasing interest in these data, especially now on how to ensure quality is high enough for regulatory decisions. Can we use real world data partially together with clinical trial data in order to make decisions on approvals? This is a hot topic, and it's really a difficult topic. So I want to talk to you about comparative effectiveness studies, because I think these are of particular interest, and this is where you have a lot of potential, but also a lot of pitfalls and biases that you have to be aware of. I think we can all agree that a prospective clinical trial is probably the best way forward when you want to compare different interventions, because you design your study prospectively, you collect the data that you actually need, both on the exposure, the treatment, the intervention, the potential biases, confounders, and you have a very high degree of completeness because you don't have all the missingness that you typically see. And this means that you can establish some causal inference quite precisely. And this you can both because you have the very thorough collection of data and variables and completeness, but also because you have a randomization that eliminates the confounding that you're not able to measure. But there is a problem with randomized trials today, and I think we all increasingly face this. First of all, the costs are really going up. There are so many regulations in place and so much work in randomized trials that they're getting so expensive to run that these are almost, or at least increasingly getting difficult to run as academic groups. And what we see now is mostly industry-sponsored trials, and even for industry, trials are very costly. There's also the timelines, because we know that it takes time to run trials. We have many competing drugs, and we have increasingly small patient numbers in oncology and hematology because of better molecular characterization of patients, and this leads to smaller patient subgroups. This doesn't make it easier to run trials as well. And then there's the ethics. Sometimes you may have situations where you will ask if it's okay to randomize if you have situations with a very dismal prognosis and you have an idea that a new treatment is very effective. The causal inference is really a key topic here when you talk about real world data and use of data outside clinical trials for determining or deciding clinical practice. So causal inferences that talk about causality if we can correlate a specific intervention with a specific outcome. And what we really want to know when we decide for clinical practice is that we want to be able to say that this was the reasons for that this intervention caused this outcome. Sometimes we're only able to say this was likely the reason for that, and maybe we are only able to say this may have been the reason for that. But generally, the two last options are what we can deduct from real-world data and non-interventional trials, and this may not be sufficient always to inform clinical practice, but there are different ways to mitigate this, and maybe at one point we will be able to really establish causal inference from real-world data studies. I want to show you this with an example. This is something we did some years ago, a review on dose intensity in diffuse large B-cell lymphoma. And as you know, for elderly patients, it's quite common practice to give dose reductions, but we don't have any randomized trials that really supports this. We have a prospective phase 2 trials with quite good outcomes, and then we have a lot of retrospective data that more or less shows in our review, and also has been shown previously, that if you are more than 80-year-old, you probably do fine with dose reduced R-CHOP, and if you're less than 80-year-old, you do better with full dose. And what you can really deduct here is that if a new 82-year-old patient enters a clinic, a dose reduction is safe and probably the best option from these data that is only non-observational, that is mainly observational data. And if you have a 79-year-old patient that enters the clinic, a full dose is probably the best option. But of course, this is a very arbitrary, and this, as I'll show you, there are some problems with these interpretations. Because really, when you look at these data and look at outcomes, you will look at the 82-year-old and say if they get full dose, the big pill glass, or the big pill glass, yes, and small dose, the little pill glass, then you would say, what are the correlations here with this decision and the outcomes? And there are so many confounders here that you cannot control for in an unobservational setting. So, for example, you have the comorbidity, you have the disease burden, you have the performance status, that all eventually plays into the likelihood of dying, either from lymphoma or non-lymphoma causes, but it also affects the choice of dosing. And these are problems we run into when we use retrospective data. We can, of course, do these multivariable adjustments. This is what we typically see in clinical trials, or sorry, in real-world data studies, but there are also some potential issues here. And this is quite important, because often we believe we solve things by doing an adjustment for disease burden or performance status, but it's important to recognize that these variables, even when we do the adjustments in a dichotomized way, they are not really dichotomized variables. So disease burden is a continuum with outcomes. So if you have very high disease burden, maybe you are less likely to survive than if you have very low, but this is not a yes or no question. This is really a continuum. And the same with performance. It's not just a question of being high performance versus low. This is a continuum of states. And these are continuums. We're not really always able to adjust for them. I can show this with an example. So if you have, for example, 4 82-year-old persons here, just a fictive example, and you look at these patients, you will see that they have very different MTVs. They have very different disease burdens, but maybe they're all stage 4 disease because of some minor bone marrow involvement done by the bone marrow biopsy. But of course, if you look at these patients and have an 84-year-old and sit as a clinician, you may think that a patient that has very limited stage 4 disease, although it is stage 4, would do well with low dose R-CHOP, whereas a patient that has a very high disease burden will do better with a high dose. And these are the kind of decisions you cannot really measure when you only adjust for example, stage 4 disease. But this, of course, influences outcome, and this may eventually lead to the fact that you measure similar outcomes with dose reduced and full dose, because it's actually different disease burdens. And this will be the case also if you adjust for stage 4 disease or just adjust for an ARBA stage. So often what we can deduct from real-world data studies, the way we do them today, where we have limited knowledge of all confounders, is really that we can look at it on a population basis and say, if you have all 80-year-old patients, it probably doesn't matter if you give full dose or low dose. But you cannot really deduct this to say, for this single patient, this single individual patients, what is the best dose here? Because you haven't controlled all the confounders. And this is something that we can maybe extrapolate a little bit to clinical trials, because often now there is a feeling that we need the real-world data to supplement the clinical trials, because the clinical trials have very strict inclusion criteria, and this means that we have a very homogeneous population of patients. I just illustrate this with a person here. Imagine we have 10 persons looking exactly like this. You may have a very high internal validity of your study, but the external validity, when you extrapolate this to a very heterogeneous population, as we know, the population we see in our clinical practice, then the external validity is probably very limited, and we know that different pharmacokinetics, maybe even different pharmacodynamics are present depending on age, sex, racial differences. But the problem is, if we start looking at the real data population and say this is what we want to extrapolate to individual patients, then we all run into a different problem, because when we look at a real world data population, we have all the heterogeneity in terms of age span, in terms of gender, in terms of sometimes also racial diversity. But the problem is that we don't really know why treatment in one patient was assigned and treatment in another patient was different. We don't know exactly why treatments were assigned, and they were definitely not assigned by at random. And this means that it's very difficult to extrapolate back and say, if you have a real-world data population, a very heterogeneous population, and you measure that some, like treatment A is better than treatment B, it's very difficult to say then, is this really then also the case for an individual patient? Because you didn't know exactly why a treatment was assigned. And this is something that is really known also from even from politics. This is citations from, I think it was a previous US minister who classified problems into known knowns, which are really the things that we know, and we know these are important. These are the things we can handle in the real world data studies. These are the things we can adjust for. And maybe there are some unknown knowns, things that we know is important, but maybe we haven't measured them. Maybe we can measure them, maybe we can collect it, and this is maybe not so big a problem either. But in real world data studies, the known unknowns are really the main issues. These are problems that we cannot really just adjust for, and we cannot really collect them. Even bigger different problem in observational data is the unknown unknowns, meaning that there are really important factors that make us decide which patients should have treatment A and which patients should have treatment B, but we are not maybe even able to explain why we are selecting as we do. This is some decision process we have internally that we cannot really deduct. And this is the advantage of randomized trials that we cannot really mimic in a observational settings. If you look at these images, you will recognize that they more or less all look a little bit like the same, but still a little bit different. This is, of course, all pictures of me and different stages of shaving and age and so on. But anyway, this is a very homogeneous population, because these are defined by very narrow inclusion-exclusion criteria. And this is really the key in a clinical trial. Often one would believe that the randomization itself is the magic bullet, but really the inclusion-exclusion criteria creates a homogeneous group of patients that you would assign to treatment A or B with equal likelihood. You wouldn't care who you assign for one treatment or the other treatment. You would dare to give both treatments to all patients. But then, of course, even if we try to make a very homogeneous patient population, they all look more or less the same, then there will be also important differences in genetics and so on, and maybe some comorbidities we haven't measured. And this is where we have the randomization. This reduces the imbalances of these remaining unknowns that we cannot really just adjust for. And then the other thing in the clinical trial that makes a huge difference compared to observational studies is that we measure all patients the same way. And if you look here on the impact of inclusion-exclusion criteria, we know that this has a huge impact on outcomes, even if you give the same treatments to patients. This was a study out of the Mayo Clinic where they looked at their population-based data, population cohorts, and looked at patients that fulfilled the inclusion criteria for Indian trial, and looked at the OS and EFS. And of course, patients that were eligible based on the organ function criteria did much better. This can, for example, be liver function, kidney function, things like this. And even if you look down here, you will see that patients that didn't fulfill the organ function criteria, they actually also had increased risk of dying from lymphoma-related causes. So it was not only comorbidity-related causes, actually also lymphoma they died for. So this means that we exclude a very high-risk group based on these organ function criteria. This is the same we saw in the Danish data. This is data we are now in process of submitting, but it was presented at ASH some years ago, where we looked at different trials and the inclusion criteria and looked at the organ function again. And you see that the overall survival is very different. The yellow marks patients that didn't fulfill the organ function criteria. The black line marks the patients that did fulfill the organ function criteria. And there's a huge difference in outcome, even if they were all treated with R-CHOP. And what's really interesting is that when we put you see the stipulated line, when we put this on our observational data, the stipulated line are the control arms from the randomized trials. We just read them with a PDF reader. You can see here that actually sometimes if we try to apply the exact similar inclusion-exclusion criteria as that was used in the clinical trial, you'll see that we can actually more or less achieve the same outcome, at least in the Remodel B study and the HOVE-184, and both of these studies were academic studies. When you look at the Goya study and the Polaris studies, both industry-sponsored studies, we couldn't really reproduce it, meaning that the outcomes of the trial control arm was actually better than the real-world data situation, even if we tried to match inclusion-exclusion criteria. And this, of course, would be a potential serious problem if you would use a real-world data population as an external control. One thing I want to talk about also is when we use real-world data to fill the gap after randomized trial, because often what we do see in randomized trial is that there's no overall survival benefit. We see maybe a PFS benefit, but we see no overall survival benefit. And then we try to explain this afterwards and say, why is there no overall survival benefit when there is a positive PFS? And reasonable explanation for this is, of course, that maybe it was not powered to show any difference in overall survival. Maybe you needed longer follow-up, or maybe it's because you had post-progression treatments and some of the patients that were in the control arm, the non-experimental arm, were anyway exposed to the new treatment in an off-trial setting after they progressed. Maybe it's also just because there really is no difference in overall survival. Then we can use observational data and compare exposed to non-exposed patients and then see if there is an overall survival difference, because in the observational settings, we often have much longer follow-up and we have the opportunity to collect many more patients. But can we really do this? And this is really an interesting study I found. This is from 2009 in JCO. And this study is not in hematology, this is in solid oncology, but I think the same goes for hematology. This was a trial where they tried to match randomized trials with observational studies that examined exactly the same problem or same intervention, and they were able to identify 350 trials that were matched in terms of randomized trials and real-world data studies. And if you look at here in this, I marked it with red. Actually, many of the studies did quite sophisticated analysis in the real-world data studies that matched the randomized trials in terms to adjust for extent of disease stage, comorbidities, even geographic regions, age. Some of them also use very advanced statistical methods such as propensity score and instrumental variable. Some of them also just use multivariable analysis, which is the common way to do this. But really, there was at least attempts to adjust for potential imbalances in the observational studies. So if you look at the hazard ratios reported by the observational studies here on the y-axis and the hazard rate reported by the randomized trials, you'll see that really there is not a good correlation. If there was to be a perfect fit, it should be the blue line, the blue stipulated line here. The actual fit between the observational studies and randomized trials is the red line, which is almost, or at least I would say, a very poor fit. This means that you have completely different results when you look at the same intervention in randomized trials and observational trials. And if you look at this plot here, the blue dots are the observational hazard ratio, and the gray area is the 95% confidence intervals. And if you look at the red dots here, these are, sorry, the blue dots are the gray areas are the 95% confidence intervals from the clinical trials, from the randomized trials. And the dots shown here, the red and blue, are the hazard ratios from the observational studies. And all the blue dots are dots that are within the 95% hazard ratio, or sorry, 95% confidence intervals of the clinical trials. But you see some of them are on the very outer part of the confidence intervals. And you have a number of, quite many actually, red dots, which are completely out of the 95% confidence interval of a randomized trial. This means even that you had studies that showed completely opposite effect. So we really have to be careful here. And it really has shown that it's quite difficult to reproduce exact data from randomized trials in an observational setting, and you can even have exactly opposite results. So meaning that intervention in a trial that maybe has no effect can have a quite significant effect in observational data. If you look at the type of, this is also quite interesting. If you look at the type, the likelihood of showing a better survival, if you look at the observational data and the randomized trials, and you have the addition of surgery as the reference, then you will see that the likelihood of showing better survival seems to be quite different. So if you have surgery as a reference in an observational study, the likelihood of having better survival when you add systemic treatment, if you compare these studies to studies that are added surgery, is really less. It seems that it's observational data that explores different new types of surgery are quite successful. If you look at the randomized trial, then it's actually quite opposite. There's much greater likelihood of showing better survival if you are exploring systemic treatment than surgery. There's of course a huge lack of randomized trials in surgery, but this really shows the key here, that it's a substantial patient selection, and in particular for surgery, in the real world setting, there is a huge selection of patients that undergo a specific surgical procedure. And this is the explanation why when you randomize in a trial between different types of surgery, and when you look at it from an observational perspective, then in the observational perspective, there has been a huge number of factors, patient fitness, comorbidities, that determine which kind of surgery a patient got, and not really by random at all, like in a trial. And this is, of course, the result of unmeasured confounding. This is one of the issues, that even if you try to adjust for all of the things you want to, the fitness and things like this, there are so many unknowns that it's difficult to completely eliminate unmeasured confounding. But there's actually another issue with observational data that we have to be aware of. And this is also the multiple testing risk, because when we have observational studies, then there is, as I said, there's a huge difference from randomized trials in that they are much cheaper to run. And this means that we can do multiple times the same question. So you can have a study from Denmark looking at one intervention. You can have a study from Sweden looking at the same intervention, and a study from Jordan looking at the same intervention. All in observational data. It's quite cheap. You can all do it, and it's something even for a PhD study. And you wouldn't see the same thing typically with a randomized trial because they're so expensive. So they are typically only run once. So in an observational study setting, you can have the situation where you test the same question multiple times, and then eventually you get positive results. So this is an issue we have to be aware of. And this is some of the final things I want to show here is something we can do to look or to better assess the bias in observational studies. So this is the case of rituximab maintenance. I don't know how you do this in Jordan, but in Denmark we used it at one point, and then I think now it's more common not to use rituximab maintenance in follicular lymphoma because there's really no overall survival benefit. And this has been shown in a clinical study. This is the study showing that rituximab maintenance really gives a much better PFS than observation. But if you look at overall survival, even with 10 years of follow-up of the PRIMA trial, then it's exactly the same. There's no survival benefit whatsoever by using rituximab maintenance. This has been explored also in observational study from Denmark. And if you look at this, this actually shows the opposite situation. So this is the top curves, the two top curves are the OS. This is for all patients, and these are for patients receiving CHOP or CHOP-like treatment. You'll see here that the blue curves are patients that receive maintenance. The red curves are patients that didn't receive maintenance, and it's much better. And it's quite interesting to see such a marked difference in overall survival in observational data when there was no absolute difference in a randomized setting. It's also unusual if you look here to the PFS, you see that there is also a much better PFS for patients that received maintenance, the blue curve, versus patients that received no maintenance, the patients that were observed. But it's quite unusual to see that this PFS difference turns into an OS difference that is almost greater than the PFS difference. So the OS benefit here in this study, of course, there are differences in terms of patient characteristics, but when you adjust for all these imbalances in anthracycline use, PP, bulky, gender, state grade 3A, then the OS benefit remains. It's better to give maintenance. And my question here is this a problem of residual confounding? For example, if you have patients in a clinical practice that had signs of early dementia or maybe some compliance issues, alcohol abuse, or other comorbidities, another cancer diagnosed during your treatment for follicular lymphoma, maybe in the interim scan you have a colon tumor that you eventually do workup for, will you also give these patients maintenance? And the answer is probably you would hesitate or at least think twice. And these are things that are not really measured when you just adjust for follicular lymphoma disease-related topics. And actually, we did a similar study in Denmark using some of the same data, but not completely. We did it in a different way. The previous study I showed was completely relying on registry data, whereas this study was based on review of medical files. And if you look here, these are there were less patients in, but we looked at only patients that were in remission after induction therapy. You'll see here that the stipulated line shows that there's still a survival benefit from having rituximab maintenance, whereas patients who didn't have maintenance, who were observed, actually had a worse survival. But then when we looked at the cause of death here, you will see that 5 of 7 deaths that occurred within 2 years after follicular lymphoma diagnosis were actually unrelated to lymphoma in the observation group. In the non-maintenance group, there was 1 lung cancer, there was 1 chronic obstructive lung disease, there was myocardial infarction and unknown cause outside hospital. And this is, of course, really concerning because these are deaths that you would not really believe that rituximab maintenance had anything to do with, or at least the decision of maintenance or not had anything to do with. But there are methods in epidemiology to really look for this, and an observational study to look for this. And one way to look for this is the negative control outcomes, which are not exactly the same as a negative control in a lab experiment, but is something that is similar. Because in contrast to lab experiments, where we also use negative control to see that nothing happens when you don't add a specific drug or a specific chemical compound or something like this, you can do something similar in observational data. But the problem here, of course, is that all exposures have already occurred, and you are not in control of any of the exposures in observational data. This was determined by something else. You are in control of exposure if you enroll patients in a trial, but not really in the typical way we use observational data. But what you can assess is the outcome. So if there are any, for example, outcomes, this is a complicated figure, I know this, but the key here is that you can have different outcomes, and you can have outcomes here, for example, an outcome that is dementia or another cancer that you would believe could be by no ways related to the use of rituximab maintenance or not, because this drug should simply not prevent, for example, breast cancer or colon cancer from occurring. We do, of course, we don't know, but at least from a conceptual point, this should not happen. And then you have the overall survival, which is the outcome of interest you're really interested in. And then you have a lot of known biases, for example, age and performance and so on, that can also affect overall survival, can also affect whether you prescribe rituximab maintenance or not, but you can adjust for this. What you cannot really adjust for is, for example, as I just said before, the comorbidity, maybe the exact comorbidity level, maybe unhealthy lifestyle that you have no measures for, or maybe poor compliance. And maybe there is some kind of correlation between age and performance in these unknown confounders. And if there is a complete correlation here, then by adjusting for age performance, you will also be adjusting for these unknown confounders. But if there's not a complete correlation, then you will have some kind of weird correlation between, for example, the fact that you gave rituximab maintenance and then an outcome that shouldn't be related at all to this. It's also frequently been used in vaccination studies where, for example, you could assess whether giving a flu vaccination prevented a hip fracture. And when you eventually show that this is the case, then you know that you have some complete uncontrolled bias in the study. So we can also look at this issue, as I just showed, with on our follicular lymphoma data. So we did it the same way. Looking just on registry data, we can see that patients that have no maintenance, the blue ones, live shorter than patients that have maintenance. The interesting thing here is that if you look at different time periods, for example, periods that were from before rituximab maintenance were even introduced, then you see that the survival is completely overlapping. So this is a little bit strange, because if you really would believe that the rituximab maintenance improved outcomes in the real world setting, not in the trials, but in the real world setting, then you would also have better survival in the later periods where you started using the maintenance, but this is not what we see. And what's also interesting is that when we look at a composite endpoint consisting of dementia and common cancers, breast, GI, prostate, and this is just an arbitrary endpoint we made, you'll see that if you have no maintenance, then it seems like these patients also are increased risk of these diseases. So this is a way to show that there can be some completely unrelated associations in observational data, because if you do not adjust for comorbidities, for all the things that make physicians decide whether to give, for example, rituximab maintenance or not, then you have a significant bias that can result in for example, an overall survival difference that has really no association with the use of the drug or not. Okay. This is my last topic of this. This is the follow-up, which we know in a randomized trials, all patients are measured the same way. This is also an issue in observational data we have to be aware of. First of all, we have to be aware of when we start the time, when we start follow-up. In a randomized trials, we always start a randomization. This is simple, but in a real-world data study, where do we start follow-up? And how do we capture our events? In a randomized trial, it's similar. It's simple. You do scan no matter which arm you are assigned for, but in a real data study, except for death, which is kind of an uncontroversial endpoint that is no debate of when you're dead or not. But otherwise, you can imagine that there are specific interventions where you would do scans more frequent or something like this, and this can eventually impact outcome. The time zero problem is a huge problem in real data studies, and this is when to start the time, especially when you're comparing different types of therapies. You can easily create an immortal time bias, and this is shown by the figure here. If you have a patient and a timeline here, and then you have the outcome could be death at one point, you want to compare different treatments, but maybe these treatments are given at different time points in the disease course. You may have one treatment here, the white one that is giving very early and the black one that is giving very late. If you compare patients that got the black one to patients that got the white one, you have an issue here because you have to live longer in order to get the black treatment or treatment A or whatever we call it. And then this creates an artificial immortal time bias that patients just by having a treatment at this point had to survive maybe 4 months after diagnosis, whereas patients that had the other treatment only need to survive 4 weeks. And when you do this type of comparisons in a retrospective study, then you artificially give one of the treatments a huge advantage. And this is something you can often see in observational studies. These are things that you see typically in maintenance studies, where if you just in a completely naive way compare patients who had a maintenance treatment to patients that didn't have, and then they start the time at the time of diagnosis, then this will create a survival bias or immortal time bias. You also see it in transplantation studies. If you compare patients that were transplanted to patients who were not transplanted, then you know that patients who had a transplant, autologous or allogeneic, had to survive maybe the first 6 months after diagnosis and also had to respond to treatment. So there's a huge selection here. The same goes for studies where you, for example, compare patients that had genomic profiling to patients that didn't have. Again, this is something that takes time. It maybe also requires the patient to be able to tolerate a period without treatment for a while. So until the genomic profiling is done. So again, here, there'll be an immortal time bias. Good. I actually have some more slides, but I think I want to stop here in the sake of time, because I think I already said quite a lot and maybe you're all very confused or not. I don't know. Yeah.
Thank you, Dr. Monarch, for this nice overview of real world data. I think this is very valid in low-income countries and for patients who are elderly that are not usually included in clinical trials. So I don't know if anybody have a question.
So, Bilal, I would like to ask you, is there any survival benefit from bevacizumab maintenance in follicular lymphomas?
So, sorry, can you ask again, please?
Is the survival benefit of bevacizumab maintenance in follicular lymphoma?
You're asking me if there is a survival benefit?
Yes.
Yeah, so no, I would say in the cases where you have randomized studies that really control for all the confounding and all the confounding that you also cannot measure by the randomization, for example, I would say that if you don't show a difference in a randomized trial, I would be quite concerned if you see a difference in non-randomized data. I would be more, I would say I would trust more in results the other way around. Sometimes you see a difference in a randomized trial, and then you don't see a difference in observational data. And I can find better explanations for this situation. For example, that some treatments are quite complicated, some treatment require quite experienced trial sites and things like this. And when you take this out to a situation in a real world setting where patients are more frail and maybe sites are not so experienced with different specific treatment, or the compliance is not the same, you don't have a study nurse, then sometimes you see that differences observed in a randomized trial cannot be reproduced in an observational setting. I would say this is probably more easy to explain than the opposite way, that you see no difference in randomized trials and a difference in observational studies. Then in this setting, I would always be very, very concerned about residual bias that you have not controlled for.
Thank you.
Thank you very much. And I think there's no more questions, and we hope to see you again in Jordan in person. Thank you very much, Doctor.
Thank you very much.
We can start. We can start.
Our next speaker is Professor Dr. Clara Montalvo from Spain. Professor Dr. Montalvo graduated in medicine and surgery from the University Autónoma de Barcelona in 1999 and obtained her specialization in medical oncology at Hospital Clinic de Barcelona 2004. She completed her training at the Massachusetts General Hospital Cancer Center, Harvard School of Medicine in Boston. In her return from the United States in 2009, she defended her doctoral thesis on resistant to targeted therapy and cancer. University de Barcelona cum laude and joined the medical oncology department at Hospital del Mar in Barcelona. In 2017 to 2018, she led the fellowship in Memorial Sloan Kettering Cancer Center, New York, liquid biopsy and gastrointestinal malignancies. Currently, she is head of the gastrointestinal cancer unit and leads a team of clinical and transitional research, novel therapies and biomarkers in colorectal cancer at Hospital del Mar Research Institute in Barcelona. Dr. Montalvo is also professor at the Pompeu Fabra University in Barcelona. Dr. Montalvo is leading and has participated in a large number of national and international projects in gastrointestinal cancer and has more than 100 publications in prestigious top journals, including Nature Medicine, where she reported the discovery of a new mutation of resistant to anti-EGFR therapy in colorectal cancer. Dr. Montalvo is staff member of the ESMO Scientific Committee in Lower GI Tumors and the ESMO Expert Committee in Liquid Biopsy, as well as the Scientific Committee of the Spanish Group of Digestive Tumors. She is the president of the Scientific Committee for Evaluation of National Grants from the Spanish Ministry of Health. Dr. Montalvo, you can start your presentation already.
Hello, can you hear me?
Yes, we can.
Thank you very much for a very nice introduction, and thank you very much for the invitation. It is a pleasure to be here today. I will now try to share my slides.
Yes. We can't see you.
Okay. Sorry, I'm having problems.
Can you start your presentation and then share it? Stop the
I'm
sharing.
having, it says that the security limitations.
You have iMac?
Yes. Let me go to settings. Sorry.
You need to give it permission to start your presentation.
Yes. I'm going to give the permission. 1 second, please. Sorry about that. I usually don't use WebEx, so my Mac doesn't have permission to share with WebEx. But okay, I will disconnect and then connect again and see if everything restarts again.
Okay, if you can't or you have some issues, you can send the presentation. We start here. Okay.
Okay. Do you prefer that I send the presentation or that I go out and then email?
So we can make sure that everything's fine. Okay.
Thank you.
Try to get in again, to relog in again. We'll give you or ask you about the permission, okay? Yes, بس الباقي مش كنت عادي تصير على الجنوب بس يعني بس انا بديت بصير كمان انا ما تكونش بصير انا كثير على كلها مش
حكيت بعد بس بيتحمل من المحاضرة
Okay. Okay, can you see now?
Yes, we can.
Okay, sorry about that. So yes, today I will be talking about biomarkers for precision medicine in metastatic colorectal cancer. These are my disclosures. So as you know, the treatment of metastatic colorectal cancer patients is a continuum of care. You go from first line to several lines of treatment, usually 3 to 4 lines of treatment, so that you reach a median overall survival of 35 to 40 months, depending on whether the patient is RAS wild type or RAS mutant. Now, to achieve this overall survival, the most important is the first line treatment, because whatever you do in the first line setting will impact the other lines of treatment. And moreover, whatever you do in the first line setting, it gives the longest progression-free survival and the highest response rate. So it is very important to carefully choose the best treatment for the first line of metastatic colorectal cancer patients. To decide this treatment, as you know very well, you have to take into consideration characteristics from the patient, the performance status, the age of the patient, the comorbidities, the prior adjuvant treatments, what the patient wants, the toxicity profile, the expectations. And on the other hand, you have to take into consideration characteristics from the tumor. That means if the tumor is giving symptoms, if the tumor is resectable, the tumor burden, and also the molecular characteristics of the tumor. And today I will be focusing my talk on this, on the tumor molecular characteristics that we need to take into consideration together with all the other characteristics to decide the best treatment for the patient. So I want to highlight this, that the molecular characteristics alone means nothing. You always have to put this in context of what the patient wants, how the patient is, the symptoms, and all that. So that said, let's go to the biomarkers that are currently recommended to treat metastatic colorectal cancer patients. Up front, before beginning any line of treatment, to better decide the first line for metastatic colorectal cancer patients, we have to test for 3 markers: BRAF mutations, RAS mutations, which means KRAS and NRAS exon 2, 3, 4, and microsatellite instability. Now, in the refractory setting, we can test for HER2 amplification and NTRK fusions because there is targeted therapy that has already shown survival advantage or a benefit advantage in these for these biomarkers. And finally, coming very soon but not yet recommended, are HER2 mutations or RET or ROS1 fusions. I will not be talking about this today. The new ESMO guidelines also say that if you don't have tissue, you can use liquid biopsy to test for all these different genomic alterations to decide the best treatment for patients. So let's begin with first line. As I was saying before, first line treatment is the most important one. So we really need to carefully decide based on these biomarkers. And you can see from this graph, from the ESMO recommendations, how BRAF, RAS, and MSI high are on top of the decision pathway. So you can see here the different options. Basically, I will be discussing now for RAS mutations, and then for BRAF, and then for MSI high. Let's begin then with RAS mutations. RAS mutations are the oldest ones. We have been using them now for more than 10 years. It is mandatory to test them in all metastatic colorectal cancer patients. And in an ideal world, it is, if possible, we should have these results within 10 days so that the patient can begin the best first-line treatment based on these mutations. So why RAS? So because we have several clinical trials, some of them very old clinical trials, showing that the survival, overall survival, and the PFS is better when we select patients without RAS mutations, and we treat them with chemotherapy plus anti-EGFR therapy. So doublet chemo plus cetuximab plus panitumumab. We all know that these patients should be bearing a tumor with no RAS mutations, and that's when we see the greater response rate and the greater overall survival and the greater PFS. So you can see here the different clinical trials, the Crystal and the Prime trial, the pivotal first-line treatment for cetuximab and panitumumab, the 181 and trial second-line for panitumumab, the Opus second-line for cetuximab, and then the randomized trials comparing anti-EGFR therapy to Avastin, the FIRE3, the CALGB, the PEAK, and the Paradigm. And all of these show that we really need to select patients for RAS mutations, and these patients will benefit. This is just an example from the Crystal study. From the left side to right side, you can see how the curves really get different when we select the patients from unselected population to KRAS exon 2 wild type to RAS wild type. As I was saying before, this is old data, but it's always good to remember this old data because this is mandatory, as I was saying before, to do in clinical practice. So basically, what we all know is that if a tumor is RAS mutant, which is half of the metastatic colorectal cancer tumors, this patient should be treated with a doublet or a triplet with anti-VEGF, Avastin. And if it's RAS wild type, which is half of the population, this patient should be treated with a doublet chemotherapy plus anti-EGFR or also VEGF antibody Avastin should be working in these populations. So focusing in RAS wild type tumors, how do we decide if these patients should be treated with anti-EGFR or anti-VEGF? Here then comes what we know about primer tumor local laterality. We know that right-sided tumors, left-sided tumors are completely different. Right-sided tumors are more common, more frequent in females, have a lower incidence. They usually are diagnosed at later stages, have more active immune system, have more mutations, more BRAF mutations, more MSI high tumors compared to left-sided tumors. And all this confers a worse prognosis for right-sided tumors. You can see in this graph how the survival is different on right-sided compared to left-sided, specifically in stage 3 and stage 4. So right-sided tumors have poor prognosis compared to left-sided tumors because of all this molecular background they have. And also, all this molecular background confers a different response to anti-EGFR therapy. So we know that left-sided tumors respond better to anti-EGFR therapy, while right-sided tumors respond better to Avastin. And this is what it says in the European recommendations, except one exception. If we have a right-sided tumor in which we're looking at fast response, then anti-EGFR therapy could be an option, could be a possibility, because in this population, anti-EGFR therapy has a higher response rate and a higher R0 resection compared to Avastin. So very simple, left-sided tumors go with anti-EGFR therapy plus a doublet, right-sided tumors go with bevacizumab plus a doublet, except if we are looking for a rapid response rate. And these recommendations, as you know, are based on 2 meta-analyses. This is one of these 2 meta-analyses, the ESMO laterality pooled analysis that was published already 6 years ago. And this meta-analysis includes all the different clinical trials that I named before, clinical trials of anti-EGFR antibodies plus chemotherapy compared to chemotherapy plus bevacizumab or chemotherapy alone. And as you can see here, regarding overall survival, if the tumor is located in the left side, it is better to treat this patient. The benefit is higher in regards of overall survival when we treat this tumor with an anti-EGFR monoclonal antibody. And if the tumor is located in the right side, you can hear down here how the benefit is better for bevacizumab, although this is crossing the line, so it's not statistically significant for bevacizumab in the right side. This is probably because numbers are very low for right-sided tumors. Now, if we look at response rate, as I was saying before, it's always better to give an anti-EGFR treatment if we are looking to have a better response rate, a rapid response rate, regardless if the tumor is located in the right or in the left. Okay, so this is what we have been doing in the last years. However, just 2 weeks ago, we had the publication from the Paradigm trial. And the Paradigm trial is really shaking all our recommendations on laterality, because what the Paradigm trial says is that if we look deeper into the molecular biology of the tumor, then right or left doesn't apply anymore. Let me tell you more about this. So these are the curves of the clinical trial. The clinical trial was positive. Overall survival was favored anti-EGFR therapy in the overall population, as you can see here in the Kaplan-Meier curve. But then, as I was saying, just last week, there was this publication in Nature Medicine saying that, sorry, this is also from the clinical trial. Now, this is the publication in Nature Medicine from last week. What they publish is this hyperselection panel, what they call hyperselection panel, So what they do is they look at the panel of different mutations of resistance to anti-EGFR therapy, including, you can see here, KRAS and RAS, BRAF, PTEN, EGFR, ECD, HER2, MET amplification, ALRET, and NTRK1 fusions. And they tested for all this panel in the blood of the patients in liquid biopsy before inclusion in the paradigm trial. And what they saw is that patients that are hyper-selected, so patients that do not have any of these mutations, they benefit more from panitumumab than bevacizumab regarding overall survival. And on the contrary, if the panel shows one of these molecular alterations, then bevacizumab is better than panitumumab. And these results are true in left-sided tumors and are also statistically significant in right-sided tumors. So in right-sided tumors, and this is what's really interesting about this publication, panitumumab is better in patients that are hyper-selected based on this molecular panel. So patients that do not have any of these mutations of resistance in the blood in a liquid biopsy before treatment, they should be treated with panitumumab. And if any of these genes are altered in the panel in liquid biopsy, then overall survival is better for bevacizumab. So really this, what I was saying, is showing that negative hyperselection using ctDNA rather than tumor sinus may identify appropriate patients for first-line anti-EGFR therapy over bevacizumab. Of course, we need other clinical trials that show the same results to be able to put this as a recommendation in the guidelines to be used. For the moment, I would say that we can stick to left versus right-sided tumors, which is an extrapolation of the molecular biology. Okay, let's now move to BRAF V600E mutations. As you know, BRAF V600E mutations occur in 10% of metastatic colorectal cancer patients. And these mutations confer poor prognosis to these patients. You can see here in blue patients with a BRAF mutations and how the overall survival is really much lower than patients without mutations or patients with KRAS mutations. Moreover, we know that BRAF V600E mutations coexist in 30% of the cases with MSI-high tumors. However, the poor prognosis of BRAF sticks and remains independently of whether the tumor is MSI-high or MSS. Now, how can we treat these patients that have a BRAF mutation? So let's go again to the ESMO European guidelines. And in the first-line setting, the recommendation is to treat these patients with a doublet plus Avastin or a triplet, FOLFOXIRI, plus Avastin in right-sided tumors in which we are looking for a fast response. What we know also for sure is that these patients should not be treated with anti-EGFR therapy. BRAF mutations confer primary resistance to anti-EGFR therapy, and this has been shown in several clinical trials, including the PICCOLO trial, and also in these meta-analysis, the Pietrantonio meta-analysis, as well as the Rowland meta-analysis. So very important key point, BRAF mutations should never be treated with anti-EGFR therapy. Now, what happens to specific targeted therapy against BRAF mutations? We have data in the first-line setting. I'm now talking about first-line setting. We have data from the ANCHOR trial. The ANCHOR trial is a phase 2 single-arm trial, very few patients that were treated with the triplet, encorafenib, binimetinib, and cetuximab. So a BRAF inhibitor, a MEK inhibitor, and cetuximab anti-EGFR inhibitor. And as you know, this data in this trial show a nice response rate. This is first line, so 50% response rate. However, the PFS was quite disappointing, less than 6 months of PFS for this population. Of course, this is a phase 2 clinical trial, single arm, and currently the randomized phase 3 clinical trial is about to finish recruitment, the Breakwater trial. which is the safety lead-in was already published several years ago, showing very promising results. And now the phase 3 clinical trial is comparing the doublet, encorafenib plus cetuximab. So no MEK inhibitor here, much better tolerance for this doublet than compared to the triplet. So doublet plus minus chemotherapy. And this chemotherapy will be either FOLFOX or FOLFIRI. As you know, safety lead-ins show very, very, as I said, promising results, especially for the FOLFIRI arm. So we're really looking forward to having this data that could show that the doublet plus chemotherapy is a good strategy in the first-line setting for mutant BRAF metastatic colorectal cancer patients. Let's move now to the second-line BRAF mutant. We know that the recommendation is the doublet, encorafenib plus cetuximab, and this is based on results from the BEACON study. The BEACON study is a phase 3 randomized clinical trial that included patients treated in the second or third line of treatment, patients with a BRAF mutant tumor that were randomized to either the doublet, the triplet, or the control arm of irinotecan-based chemotherapy plus cetuximab. Co-primary endpoints, overall survival and response rate. And as you know, this is a positive trial. You can see here the median, the overall survival Kaplan-Meier curve, median overall survival of 9.3 months for both the triplet and the doublet compared to 5.9 months of the control arm. Statistically significant with hazard ratio of 0.6. So a really positive trial. And also in regards of response rate, you can see down here how response rate for the triplet was 27%, 28% for the doublet, so a little bit lower, and this 2% for the control arm. We have to remember that here we are dealing with refractory metastatic colorectal cancer patients in which we do not have too many therapeutic options. So it's really an unmet clinical need to find a good treatment with this kind of responses that we see in the BEACON trial in this population of patients. Let's now move to what is recommended in the refractory. I just discussed now the RAS, the BRAF mutations, which are recommended in first line. I will not go into MSI high tumors because I'm talking about targeted therapy. I'm not talking about immunotherapy because of time of the presentation. So let's now move to the refractory setting. In the refractory setting, what the ESMO guidelines recommend is to check for HER2 amplification and track fusions. Let me remember what I was just saying before, that in this refractory setting, it's really an unmet clinical need to find good treatments. So far, we had results from TAS-102 and from regorafenib showing this response rate of 1-2% and this PFS of less than 6 months, less than 3 months. So it's really an unmet clinical need. We recently had data from the Sunlight study. As you know, the Sunlight study compared TAS-102 as a control arm to TAS-102 plus bevacizumab. And the Sunlight study was a positive study. The primary endpoint of the Sunlight was overall survival. You can see here how the combination of bevacizumab plus TAS-102, Lonsurf, was much better than Lonsurf alone, with a median overall survival of 10.8 months compared to 7.5 months. So really the Sunlight strategy, TAS-102 plus bevacizumab, has become the standard of care for refractory metastatic colorectal cancer patients. So patients that have received all the chemotherapy, the 5-FU, oxaliplatin, irinotecan, bevacizumab, anti-EGFR therapy. These patients in second, third, fourth, or further lines can be treated with, or should be treated with, the Sunlight strategy. However, there's still a lot to do in this setting. So it is really mandatory to look for new biomarkers and to find new strategies, targeted therapy to treat these patients. And here we go to review now the data from HER2 amplification. There are several small single-arm phase 2 clinical trials using different strategies to target HER2. What we know about targeting HER2 in metastatic colorectal cancer is that we need to use a doublet targeting. So using only lapatinib or using only trastuzumab is not enough. We really need to look to use doublets to have a real knockdown of the pathway and to have real good efficacy results. So you can see here how all the different clinical trials used doublets or anti-HER2 therapy plus chemotherapy. We also know that HER2 amplifications are enriched in RAS wild-type tumors. So usually these trials use RAS wild-type as a molecular selection. And you can see here the different names of the different clinical trials. As I was saying, phase 2 single-arm studies with low numbers of patients, but we see most the same results for all these phase 2 clinical trials. Response rate usually 30%. I would say that the Destiny show a 45% response rate, which doesn't really mean anything. This is only a phase 2 single-arm clinical trial, so these results need to be shown in larger randomized clinical trials. PFS in most trials around 4 to 5 months. So this is good data. This is the refractory setting. So this is good data. The Mountaineer with tucatinib showed this PFS of 8.2 months, but again, this is a phase 2 single-arm study. What we also know is that the response rate correlates very well with the level of HER2 overexpression amplification. So patients that have very high levels of amplification are the very good responders. We also know that we can use liquid biopsy to check for the response. If we see a decline in HER2 amplification in the liquid biopsy, early decline, these are the patients that will be responding later on. And of course, we need to see data of randomized clinical trials and data in earlier lines of treatment. And these are what the clinical trials that are ongoing for HER2. The Mountaineer 3 clinical trial, it's in the first line. Patients are selected with HER2 amplification and RAS wild type and are randomized 1-to-1 to FOLFOX plus tucatinib plus trastuzumab, so chemo plus HER2 inhibitors, and compared to standard of care. Primary endpoint, it's PFS. And then we have also the SWOG 1613 clinical trial, which is in the refractory setting, second, third line, also includes HER2 positive RAS wild type tumors, and it's comparing 1-to-1 trastuzumab to cetuximab irinotecan as the standard of care. Primary objective, again, it's a PFS. So we're looking forward to results from these trials to see if really HER2 is moving to earlier lines and is also moving with combined with chemotherapy. Now I will talk briefly in the next minutes about KRAS G12C mutation. You know that KRAS G12C mutations are quite rare in metastatic colorectal cancer compared to other tumors such as lung cancer. We know that KRAS G12C mutations confer poor prognosis to patients having these mutations in their tumor. And we know that initial clinical trials, phase 1 clinical trials with single targeted therapies, sotorasib or adagrasib against KRAS G12C were negative or show very poor results as single agent in metastatic colorectal cancer. You can see here results in lung cancer, this very nice response rate of 32%, but response rate for colorectal was only 7% when using these drugs alone without anti-EGFR therapy. We know that alone these drugs do not work because there is a reactivation of EGFR, the same thing that happens with BRAF. So these drugs should be combined with EGFR inhibitors. So other development of KRAS G12C metastatic colorectal cancer is combining sotorasib or adagrasib with either panitumumab or cetuximab. And these are the ongoing phase 3 clinical trials. We have phase 1 clinical trials with very promising data, and these are the ongoing phase 3 clinical trials. The Crystal-10 trial is is including patients with a KRAS G12C mutation and is randomizing these patients in the first line setting, is randomizing these patients to chemotherapy as the standard of care compared to cetuximab plus adagrasib. There's a dual primary endpoint for the Crystal-10 study of PFS and OS, and we hope to see results pretty soon. The CodeBreak 300 trial was presented at ESMO last year. The CodeBreak 300 trial included patients with a KRAS G12C mutation in further lines of treatment, so second or third line of treatment, and it compares panitumumab plus sotorasib versus investigator's choice of regorafenib or TAS-102. Primary endpoint is the PFS, and as I said, this was presented at ESMO last year. It was the plenary session presented by Filippo Pietrantonio, and it's a positive trial. These are the results for the primary endpoint of PFS. The trial assessed 2 different doses of sotorasib, a dose of 960, a dose of 240, compared to TAS-102 or regorafenib investigator's choice. And you can see the median PFS was higher for the sotorasib 960 mg plus panitumumab in green here, with a median PFS of 5.6 compared to 3.9 and 2.2, and this has a ratio of 0.5. The toxicity also was different from soto plus pani compared to investigator's choice. Soto plus pani gave more skin toxicity and more hypomagnesemia and diarrhea compared to investigator's choice. Remember, investigator's choice was TAS-102 or regorafenib, so these patients had more neutropenia, nausea, and anemia. So this is what's happening with KRAS-G12C. And now let me finish in the last minutes to re-challenge with anti-EGFR therapy by using liquid biopsy to select for biomarkers of resistance. So we all know that we can use liquid biopsy to track the different mutations of resistance to anti-EGFR therapy. When we treat patients with panitumumab or with cetuximab, we know that there's different subclones of resistance that bear mutations in RAS, mutations in BRAF, mutations in EGFR extracellular domain, and these clones of resistance are selected. So with cetuximab, we are killing the clones that do not have these mutations of resistance, and we are allowing these clones of resistance to emerge and expand, and then finally give rise to progression disease. You can see here examples of different patients treated with cetuximab and how the different sun clones shown in different colors are emerging in the blood of the patients during treatment. However, we also know that if we stop cetuximab treatment and we leave this patient without anti-EGFR therapy for at least 3 to 4 months, then these clones of resistance decrease in the blood of the patients, so that this patient is again mostly RAS wild type. The tumor is mostly RAS wild type, and we can potentially retreat this tumor with anti-EGFR therapy with cetuximab, and potentially this tumor could be responding again to this re-challenge with anti-EGFR therapy because the tumor is mostly RAS wild type with no mutations of resistance. So this concept that had been shown in different cohorts of patients in different preclinical studies was studied in the Kronos trial. The Kronos trial is a very pure, a very academic trial that evaluated re-challenge with panitumumab in the first based on liquid biopsy selection. So the Kronos trial included patients that had received cetuximab or panitumumab in the first line, then had stopped treatment for a few months, And then a liquid biopsy was performed. And if this liquid biopsy showed mutation zero means no detection of mutations of resistance, no mutations in RAS, no mutations in BRAF, no mutations in EGFR. If the liquid biopsy was mutation zero, then the patient was included in the Kronos trial and treated with panitumumab. And what the Kronos trial showed was a response rate of 30%, so and a PFS of 16.4 weeks. So we have to remember that this is in the refractory setting. These patients had received several lines of treatment before re-entering the anti-EGFR therapy. So these results are very, very promising. And these results are now being evaluated in a randomized clinical trial, the CITRIC trial, that has just finished recruitment. So we should very soon see if these very nice results still stand in a randomized trial. But again, based on biomarkers, rechallenge based on biomarkers detected in the liquid biopsy could be a possibility for these patients, metastatic colorectal cancer patients. So take-home messages, very, very briefly. We need to remember that ESMO, that the American guidelines, that the Asian guidelines recommend testing of RAS mutations, BRAF mutations, and macrocytosol stability to decide the best treatment strategy for patients with metastatic colorectal cancer in the first-line setting. That later on, in later lines of treatment, we have efficacy has been shown for HER2 amplification and for NTRK fusions. Sorry, I did not show the data for NTRK fusions, but because it's not accepted still in many countries. But results are very similar to what we see in HER2 amplification with response rate around 30%. And then finally, we have to remember that in the refractory setting, a challenge with an anti-EGFR therapy, it's a possibility in patients that have been, in patients that have a liquid biopsy that is not showing mutations of resistance. In case we do not have a liquid biopsy, we could also use clinical criteria to select patients for a rechallenge. And basically what we could do is patients that have had a very good response in the first line treatment and then did not receive anti-EGFR therapy for at least 4 months, we could retreat these patients and see if they respond. So thank you very much. With this, I finish with this picture of Barcelona and Hospital del Mar in where I work here in the front line of the Mediterranean Ocean. So thank you very much. I am open to questions. Thank you. Okay, I see. I'm reading some questions here. So there's one question. Should I go ahead and read the questions?
Yes, please.
Yes.
Yes, there's one question from our colleague, Ms. Salama. Do you have any explanation why malignant colon cancer cells lose HER2 amplification in advanced stage comparing to early stages?
Okay, we know that different HER2 amplifications and different mutations change during the course of the disease. And I think this is a very important concept, the heterogeneity within a tumor, but also the heterogeneity during time. And this is usually due to the fact that we either select clones because of treatment. So when we give different treatments, we are selecting different clones of resistance. And also due to the fact that the most aggressive clones are the ones that survive over time. So really the mutations or the genomic alterations that coexist with throughout the course of the disease are the truncal mutations, APC, P53 mutations, but then the other subclonal alterations can change during the course of the disease. And this happens with HER2 amplification. For example, HER2 amplification arises during anti-EGFR therapy, We know that HER2 amplification is a mechanism of acquired resistance to to anti-EGFR therapy. So yes, HER2 can either decrease or increase depending on different treatments that we give to this patient.
Thank you very much.
Thank you very much for the nice overview. I want just to ask you, some patients, they go and do liquid biopsy or NGS bilateral. We know that we test first the KRAS and RAS, BRAF, and MSI for first-line treatment, but we sometimes are faced with patients bringing their NGS with them with the first encounter. So sometimes I know NTRK mutation is so rare, but when you find it in the test, what do you do? Do you start with NTRK inhibitor, or we go down what we know with the first line treatment?
Okay, that's a very good question. So I am doing NGS, and we have been doing in my center NGS for several years now, and I have only seen one patient with an NTRK fusion. So it's really very infrequent.
I have
but of
one.
course, okay, fantastic. So the NTRK is in refractory patients. So we should go first for what we know, the FOLFOX, the FOLFIRI, and then in the refractory setting, we could go and give these patients an NTRK targeted therapy. That's what we should do. And NTRK usually do not change during the course of the disease. So we have an NGS performed before any treatment, and this NTRK fusion should probably stick and still be there in later lines of treatment. So my recommendation is to do NGS because you have a broader picture of everything. But it's true that when you do NGS, sometimes you find things that you really don't know what to do with them, or that you really don't have treatment for these alterations. And this is the case for what happens with NTRK.
Yeah, and do they have durable responses with the NTRK mutation, with the NTRK inhibitors? Durable.
Sorry, I didn't. Do you have? Sorry.
Durable responses with the NTRK.
Better responses. Durable responses. No, yes. No. So the problem with NTRK targeted therapy is that PFS is quite short, and responses are not very durable. That's one of the limitations. Yes.
If no more questions, then thank you very much once more, and we hope to see you in the future here.
Thank you.
Good afternoon. Welcome to our last lecture for today. I am Dr. Nadir Abdin, the chairman of Scientific Committee for this conference. It gives me a great pleasure to welcome Professor Sherko Kumal from Germany. Professor Kumal is the clinical director and chairman of the Interdisciplinary Breast Unity Clinics of Eastern Unity in Germany, and he's leading the breast cancer research program. He is the executive board member of the Gynecology Working Group and the director of West German Study Working Group and the Academic Group for Breast Cancer. He is qualified as an extraordinary professor at the Medical School of the Humboldt University Berlin in Germany. He is a faculty of the ESMO and the ESMO Scientific Committee. He is a member of both the Scientific Board of Oncoplastic Breast Surgery and the Scientific Committee of National and International Symposium on Breast Cancer and Surgical Oncology. His CV is great. Rich, for as a primary investigator, he is a chief investigator of 33 national and international phase 1 to 3 clinical studies and principal investigator for more than 85 phase 1B to 3 clinical trials. He co-authored over 230 publications and almost 60 books and chapters, and he presented many lectures in congresses, abstracts, and proceedings. And he's going to update us on the triple-negative breast cancer, unleashing new horizons within immune therapy in the early and metastatic setting in the triple-negative breast cancer. The floor is yours, Dr. Shevko, to start your lecture.
Many thanks for this really kind introduction. First of all, I want to ask, you can listen me?
Yes,
okay, perfect. Yes. So now let's share my slides. So it's written here, it takes a moment to...
Okay.
So if you start to see something, can you tell me?
Still not okay. Okay, now we start. Yes.
Okay.
The slides are here now.
Okay, perfect. So let's talk about triple-negative breast cancer and where we are and what we get in progress in the last maybe few years. I think this is maybe most interesting. So these are my disclosures. First of all, let's talk about the introduction. And we often see this picture maybe in congresses and meetings to say we have gene expression subtypes, maybe the Lehman classification and other classifications, but actually at the future, I don't know if you need this one exactly for basal-like, luminal cancers, etc. What we learned, I think, and this is interesting, is that we learned that probably for the PLA1 expression for the metastatic situations, we have to use immune therapy. What we learned additionally is if we have a germline mutation, we have the inhibition of PARP inhibitors, I think is effective for patients. And then we have the antibody-drug conjugates, and then we have TROP2 antibodies, but this is not like a targeted individualized therapy. It's working on different aspects of level of TROP2 expression, HER2 expressions, etc. This is what we have to say. We don't go out of the targeted therapy just a bit. AKT inhibitors, some trials says yes, it's working in triple-negative situations, and anti-androgen may be something for luminal cancers in triple-negative phases in the future. So this is a little bit the picture when we thought of the heterogeneity of this triple-negative diseases, where we are and what data we have today. So it is, of course, always overlapping of the heterogeneity in case of different tumor types in triple-negative situations. And first of all, we have to ask the questions, who benefits from systemic therapy for early triple-negative disease? And the question is, if we have maybe screening population, triple-negative, a lot of, maybe 40% of the patients are stage 1 disease triple-negative. And if you look at the data, so we see that probably the chemotherapy is the backbone of triple-negative disease breast cancer patients. And we see that always the chemotherapy has a benefit for these patients and a lot of benefit for patients in lower stages, maybe stage 1, less than 2 centimeters. So what we learned is that we have to give the therapy in the high-risk situations more and more neoadjuvant prior to surgery. I think this is more effective for the patients. So let's focus on that one. If all patients will benefit in stage 1 disease from chemotherapy, actually we don't know. And the group from the Netherlands, they analyzed if the TILs are not that high for these patients. And all these patients in this analysis never get the chemotherapy. But if we have high TILs without any chemotherapy, the survival is really good for these patients. This is only just a little bit hypothesis driven. It's nothing for me like in the future to say, I measure the TILs for 1 centimeter tumor and then decide a chemo yes or no. It's only something what we think about maybe for de-escalation of different kinds of chemo after all these results. So if we summarize stage 1 disease triple-negative early breast cancer, First of all, we have to summarize there's no proven standard to say is this anthracyclines followed by paclitaxel? Is it only paclitaxel platinum or AC paclitaxel, those 10 situations? And what we are doing with capecitabine in that situations, in case of non-PCR, this is a little bit I start with the stage 1 disease. I love to take paclitaxel and platinum in the combination 12 weeks, mostly for these patients. And in case of non-PCR, maybe with a higher RCB scoring, starting with capecitabine. So let's focus just again for pre or post-operative situations. If we look for historical NSABP 18 trial, I think it was quite similar. We have the chemo after adjuvant or prior neoadjuvant. The results were comparable for this one. So, but now we have more and more downstaging regulations, and the first questions, because of de-escalation of surgery, targeted axillary dissection, etc., always is the questions: do we have treatment algorithms after neoadjuvant strategies because of the downregulations of the tumors in that situation? This is the important factor to implement neoadjuvant strategies for these patients. The question is what we do with post-CR patients if we have pathological free situations, no invasive tumor cells, or residual disease. What we saw is in the meta-analysis from the FDA, from different trials, neoadjuvant trials, that the PCR is a surrogate for survival in high-risk breast cancer patients. What we saw additionally in the CREATE-X trial, if we're using triple-negative patients, capecitabine, most of these patients never get platinum before, then maybe the patients have a benefit from the addition of another therapy in residual disease. So that raises the questions: can response to neoadjuvant chemotherapy used to tailor our treatment decisions? So it means, can escalation in patients with residual disease after neoadjuvant therapy improves outcome? This is the question. And let's look at the data. We have to create X trial, mostly not given platinum before in the neoadjuvant situation. So I think this is a little bit different what we saw. But we saw that capecitabine was effective and mostly driven from the triple-negative cohort in this trial. Now the question is what we know about capecitabine as a maybe treatment effect after non-post-CR patients. First of all, we have the CIBOMA trial, capecitabine and placebo. And I think a little bit surprising, we saw that at the basal-like signature, there was no effect of addition to capecitabine, non-basal-likes of the PIM50 effect. The same situation we saw at the ECOG trial from the United States, capecitabine plus platinum trial. Again, that the non-basal likes have a benefit from capecitabine and basal likes not. I think if you summarize this data, I think these data as mostly from neoadjuvant trials and cannot be extrapolated to neoadjuvant strategies. I think it's the same situation in both trials, but it's not prospective testing. So we don't do in our daily routine to say, I do a genetic testing and then looking if capecitabine is working or not. But I think it's interesting, maybe for the future, think about it. Who have a benefit if I don't start probably with immuno-oncology and I start with capecitabine in addition? The next question is, can adjuvant therapy improve our outcome in patients with residual disease after the neoadjuvant strategy? Yes, in patients with Germline mutations, we have the Olympia trial. You see patients with a non-PCR given olaparib for 1 year, the patients had an overall survival benefit. But once again, I think we have to take into account, these are mostly patients without platinum in the neoadjuvant strategy. And of course, I'm thinking that platinum in the neoadjuvant strategy, this is another situation, it's the patient coming out with a non-residual disease or residual disease in that situation, if giving platinum before. Can we improve the response to neoadjuvant situations? And now we come to the questions, platinum, yes, no, in the neoadjuvant strategies for these patients, triple negative, maybe stage 1, stage 2, stage 3 disease. Platinum, yes or no? I think this is a big question. If you look at all the data, so we saw at the GPA6, firstly, yes, always we have a higher PCR rate in different trials, but it takes, maybe we have around 50% PCR rate if we have added carboplatin to the neoadjuvant strategy. The question is, is it translated to overall or distant disease-free survival or invasive disease-free survival? The GIPA-6 trial, yes. CIGB trial, no. That's why it was maybe a decade with no other knowledge, but now in the brightness trial and the Tata Memorial trial, we saw a difference of better survival because of the addition of platinum. So a translation of higher PCR to better survival. And now I think for escalation, de-escalation questions in that situations, what I'm showing you is the questions is, does it matter how the PCR is achieved? So the questions is, after maybe 8 to 12 weeks getting a PCR, is it the same surrogate after 18 or 24 weeks? I think actually we have mostly 18 to 24 weeks of chemotherapy and the PCR and non-PCR question. Is the quality of the PCR equivalent of the shorter treatment duration? We only have to try from the WSG, from our group, gem-carbo or carbopaclitaxel. And a lot of patients after 12 weeks of PCR, getting a PCR, never get an additional chemotherapy. What does the trial shows us? It's only a phase 2 trial. This trial shows us the PCR is a surrogate for survival, despite you don't get maybe anthracyclines afterwards. This is an interesting question. We had a huge difference of more than 20% between platinum and taxane versus gem-carbo in case of PCR. But if you look at the lower curve, you see the same survival for these patients. Why that happens? Because the patients getting a non-PCR and lower non-PCR in the gem-carbo group, most of these patients get AC afterwards, the anthracyclines, and so you see the same survival for that one. So it seems to be that a PCR after lower maybe duration of treatment therapy is a surrogate for survival and is efficient for the patients. I think this is a strong situation for us, and maybe a little bit for me the translation why I'm using platinum and taxanes in the stage 1 disease as the best backbone for patients and that situations. If I get the PCR for these patients after neoadjuvant strategy, I don't go for anthracyclines probably. So, but of course, this is a phase 2 trial, and the implications of optimal adjuvant therapy of non-PCR patients after shorter therapy is quite unclear. And now let's go on to the BRCA situations. Nearly 20% of our patients in triple-negative disease have a BRCA or higher HRD status. And is this related because in the maybe decades ago, we thought platinum is more effective in germline mutated patients, but the story was not true for maybe neoadjuvant strategies. We don't see that if we give platinum additional, it's dependent on the germline mutation status. How is the PCR rated? At the HRD scoring, the same. We have to try yes and we try no. Maybe we can't separate the patients to give platinum yes or no because of germline mutation or HRD scoring. I think this is maybe an important knowledge what we had in the last few years. And now we come that maybe if you look at the data, we had the first of all 20% PCR, then 50%, and now maybe Keynote 522, 65% of PCR if we get everything so in that situation. And the question is, can surgery be de-escalated for these patients in case of responders? If you look, maybe the surgical questions is breast conserving surgery or mastectomy. We have the data, it's quite the same efficacy in case of maybe local relapse rate if there are no mutational situations like BRCA is. Maybe surgery in case of clinically complete remission, we don't have any data for that. Surgery case in BRCA, we saw that the BRCA1 mutation patients probably benefit more from the contralateral side. I think this is important to think about this for prophylactic surgeries. And the most hot topic now is de-escalation for lymph node positive patients converted to lymph node negative because of the neoadjuvant chemotherapy strategy. And can we de-escalate it in case of sentinel and targeted lymph node dissection? The questions is, if we rising all these questions is, how is it with the downstaging of the axilla? Can we escalate or de-escalate it if we have clinically not negative? Most of the patients have clinically not negative after, maybe it's more than 98% for these patients of the neoadjuvant strategy. The most interesting point is if the patients have a breast PCR on converted lymph nodes clinically, most of these patients have a negative axilla. I think these are strategies for de-escalation for the patients and maybe the prototype for clinically complete remission to say these are the patients probably where you can de-escalate and make targeted axillary dissection. If you have larger tumor burden, you see again nearly 90% of conversion of 3 or 4 positive lymph nodes because of the neoadjuvant chemotherapy strategies. So how are the data, and is this reliable for our patients? And I'm saying, yes, we tested the feasibility in the center trial. Is it feasible for the false negative rate if you only resected the targeted lymph node, the biopsy proven and marked lymph node? Or do we need the sentinel additionally for that? And actually for this data, we need the sentinel lymph node in converted lymph node from positive to negative because of the neoadjuvant treatment strategy. I think now we have the data of the feasibility for these patients. And the most important point for me is always in oncology, is it safe for the patient because of oncological endpoints? And this is the only trial for clip-marked lymph node. It's the center trial, and that's why we published in JAMA Surgery. It's with the same efficacy if you de-escalated the axillary dissection to targeted axillary dissection. It seems to be that it's safe for the patient in case of oncological endpoints. So let's move on to stage 2 and 3. And first of all, I start with the case. And this is a little bit tricky to say where we are. I think in the endocrine positive situations, we're coming more and more to endocrine response questions and dealing chemo yes, no questions. Here we have a patient maybe with higher Ki67. It is just a bit low ER positivity, PR positivity. So I don't know, we don't know exactly what this kind of patients. It's triple negative or is it ER low, not really, etc. Which therapy in that situation? The first is to say, maybe let's make the surgery, or which kind of chemotherapy we're doing, or maybe to start with surgery and looking afterwards what the pathologist is telling me after the surgery on the whole specimen. Or is it endocrine sensitive? Do I have to give this patients later 5 years of endocrine therapy? I don't know at that situation. Or what we did is, in case of all the other decisions, CT scanning, etc., our decision was 2 weeks of aromatase inhibitors with an ovarian suppression, and afterwards a rebiopsy. For us, it's not the question to say, can we omit or de-escalate for chemo? But the question for me is, what kind of chemo is the best for these patients? And what happens, and this is a rare case, but we saw this, after rebiopsy, we had a clearly ER low situation, and we have a clearly triple negative situation. So we started with platinum, we never give this before, and we started with pembrolizumab with the addition of this maybe additional, survival aspect. If you change your neoadjuvant treatment strategy, you never give an ER positive, mainly platinum, and you never give, until this time, pembrolizumab for these patients. And we had the PCR afterwards. And for me, the second point is clear. These patients never need an endocrine therapy afterwards for 5 years. So, and now we come to the keynote 522, where we only treated patients with really triple negative situations with a chemotherapy backbone, like we saw maybe in my first slides of my talk, anthracyclines, taxanes, and platins, plus minus pembrolizumab. And you know the data, that we had a huge difference in PCR rates, mostly for positive lymph nodes, but in negative lymph nodes too. And if you look at the latest data for survival, you see again, you have better survival because of the addition of pembrolizumab to the classical chemotherapy as an neoadjuvant part and 9 cycles additionally as an adjuvant situation. It's always questioning, is this at negative or not positive? And you see all patient groups have the survival benefit for these maybe specific questions, what we are using. And then the questions is always, if I got the PCR because of pembrolizumab and chemotherapy in a neoadjuvant strategy and give it further, despite of the PCR, how is the difference? And now we have the difference after 5 years, and you see the curves doesn't change and doesn't drop down more after 5 years. It's a difference of 4%. Because despite of a PCR, giving immune checkpoints, giving pembrolizumab, additionally in the completion of 1 year. So, and once again, so how is it for patients with stage 1 lymph node negative situations where we're already discussing, do we need this? And if you look at the data, yes, it's true. and look at the distant recurrences, I think this is the main driver for me to see how we can cure patients. You see, always patients in that stage have a benefit of additional usage of pembrolizumab. But on the other hand, of course, we always have to deal, and that's why I focused maybe in given all the data and the latest data together, we have, of course, using pembrolizumab as an immune checkpoint. In the addition, we have additional side effects comparing to placebo group. This is quite clear, maybe 10% versus 2%. That situation's mostly what we know as oncologists, if using maybe for thyroids and rashes, etc. And then the question arises, what we are doing in special cases, maybe BRCA cases, non-PCR cases, do we combine pembrolizumab or olaparib? If I can, free of choice, not insurance-based, etc., I would say yes, the combination is a factor for the patients. The question is pembrolizumab and capecitabine. In case of non-PCR patients, we think yes. And more answers maybe we get from the KEELING trial. This is a trial in metastatic situations, but we saw the addition maybe for responder patients, olaparib and pembrolizumab versus chemo, classical chemo and pembrolizumab. You see, of course, in the BRCA patients, olaparib combination with pembrolizumab was effective. And this is the main point. In case of side effects, it was better than the classical chemotherapy. So we have more and more data, not randomized data, but probably that the combinations is feasible and has a high efficacy. So my summary for early breast cancer situations, triple-negative disease, is pembrolizumab is the new standard in neoadjuvant, post-neoadjuvant strategies for stage 2 and 3 disease. PD-L1 expression is not a predictive factor. It's really important. This is a completely different situation to metastatic situations, and possible combination therapies, especially for the non-PCR group in the adjuvant therapy phase, are still unclear. So future directions where we have to think about de-escalations at stage 1, ADCs plus immune therapy, we don't know. Chemo-free combinations, maybe that could be the future. Stage 2 and 3, how do we convert something more tailored treatment decision? Platinum is at the end an immune therapy, not completely clear. And that situation, chemo and immunotherapy, I think this is the standard backbone. I think in the past you asked the questions, do we need other therapies for that one? In residual disease, I think there's an unmet need to do additionally therapy for these patients, maybe in the future, and the trials are running with ADC in combination with immune therapy. So we started in the WC together with Peter Schmidt. So we started, I think now it's starting in the next few weeks, the triple-negative trial for early breast cancer disease at stage 1, where we only give ADCs plus minus pembrolizumab and looking if we can, this kind of de-escalation of chemo as an ADC, different lengths of therapy to see how we get further with the efficacy for these patients. So let's make a little break, so emotionally, and because now we're coming after this huge topic for triple-negative early breast cancer situations to the metastatic situation. I think the background, once again, and this, if I showed this slide, I think it happens to me a lot of what it changed in the last 4, 5, 6 years. I think in 2018, in case of we say a negative, BRCA negative, PD-L1 was not measuring. We had the chemotherapy, we have taxanes, maybe bevacizumab questions, platinum combinations, eribulin, capecitabine, etc. Not more. So then it's coming platinum, then it's coming capecitabine, and we had the implemented PARP inhibition after Olympia and the BRCA trials with efficacy as a monotherapy versus chemotherapy. So if you look at that one, I think the response rates are comparable in case of maybe disease-free survival, and mostly different if you don't have prior chemotherapy for that one. I think we don't have the huge groups to compare everything for that one. So what we can assume and summarize, the PARP inhibition is working. And in some cases, we can implement it maybe in what we're doing in the later lines to give PARP inhibitors if we have a germline mutation, or if we have a PARP2 mutations or somatic BRCA mutation, if you look at the data. Let's come to moving to immuno-oncology. And immuno-oncology was first developed in metastatic situations. And what we saw is that it was working in first-line situations. If we're coming in later lines, metastatic situations, I think the immunotherapy was not so effective. What we saw, the patients with efficacy because of addition of immune therapy, this is the monotherapy, that situations have a high duration of response. And we saw the patients with a clinical, maybe complete remission, metastatic situations have a long-lasting treatment situations we never saw in triple-negative disease patients before. Then we get to trials, the IMpassion130 trial with atezolizumab in combination with nab-paclitaxel, or the KEYNOTE-345 trial with pembrolizumab in different backbones of chemotherapy. Different endpoints and different strategy of testing. Mostly now it's using pembrolizumab plus different kinds of chemotherapy, and then we have to use the CPS scoring for our patients. So by the first trial, 2018 came out in the overall survival benefit for atezolizumab with nab-paclitaxel. And the question was, does this happen with adult taxanes too? And the answer was, in the IMpassion131 trial with paclitaxel as a normal standard of care, was not true. Atezolizumab was not effective in combination with paclitaxel. That leads that the FDA and EMA said this is probably not the therapy and standard of care in that situation. So, and then it came out the KEYNOTE-345 study, and there we learned after CPS scoring more than 10 or equally 10, we have the efficacy for the patients if the addition of pembrolizumab with different backbones of chemotherapy. If you need taxanes, nab-paclitaxel, gem-carbo combinations, etc. So this is a summary of the different trials, and the trial was practice changing in the world was the KEYNOTE-355 trial using pembrolizumab with different backbones of chemo. I told you before. And then we think about what's happened in the second line mostly. And is there a role of immune therapy? Mostly not, I showed you before, but there are interesting results from another KEYNOTE trial. And there we show if the CPS scoring in later lines is higher than normally expected, and this is maybe 20% of the patients, then we have a higher rate of response. And this is the response with pembrolizumab monotherapy without combination of chemotherapy in that situation. And you see, if you have higher immunogenic tumors in the later lines, there is an efficacy for that one. It's not a standard of care, but only think about it, amount immunophenotypes for these patients. So my take-home message for the metastatic situations is the chemoimmunotherapy is the standard in the first-line treatment of metastatic triple-negative disease, and differentially to the early breast cancer situations, it must be PD-L1 positive. In pembrolizumab, various chemotherapies can be combined. We have to use the CPS scoring. And additionally, what we learned from basket trials that MSI high patients is really rare situations from breast cancer patients. Pembrolizumab monotherapy has an efficacy. So then we come maybe only short view for 2 minutes for the antibody drug conjugates coming maybe more and more in triple-negative disease with different kinds of datopotamab, begonia trials, sacituzumab proven because of the trials of the Ascent trial, trastuzumab deruxtecan situations because of the Destiny trials, etc. And that's why we're using in daily routine sacituzumab because of the Ascent trial and trastuzumab deruxtecan because of the Destiny 04 trial using ADCs in triple-negative disease metastatic patients. The question is it dependent on HER2-low situations? Yes, we have a lot of shifting. We have a lot of different situations. What we're doing, if we have one HER2-low signal, despite in the early or later lines when biopsies, we give the patients trastuzumab deruxtecan in the later lines for these patients, and mostly it's effective. We have more and more data that if it's HER2-low or nano-low, it's working for trastuzumab deruxtecan or maybe sacituzumab with impressive data for HER2-low and for HER2-negative patients too. So if we combine and focus and summarize my talk about what options we have today and what is the difference to 23 and 24 where we are more and more, I think we have implemented platinum germline mutation patients treated with PARP inhibition with olaparib. We have the immune therapies implemented in the neoadjuvant early breast cancer situations. We have implemented maybe olaparib in non-residual disease. We have chemoimmunotherapy implemented in the metastatic situation, first line, and we have implemented the ADCs This is the standard of care treatment and the proven situations what we are, and what is the picture of 2024. So of course, the question is where we have to think about in the future, the role of maybe immune therapy coming from the adjuvant and neoadjuvant situations in the metastatic situations, re-challenging, this is the questions. Role of ADCs in combinations with IO is a big question. Which is the best sequencing of the ADCs? No one knows at that time. And maybe the next drugs, maybe generation and damage drugs are waiting to coming in the trials and coming to improve, hopefully, further the efficacy for our patients. So then I have to say thank you for this maybe short overview of triple negative disease and where we are today. Thank you very much.
Thank you so much. Thank you so much for this excellent presentation, Dr. Komel. I had planning to have 2 or 3 questions. You answered them in your presentation. Excellent presentation. So anyone can from the audience, if any questions, please. I have a question in the metastatic setting. When you have a PD-L1 positive metastatic breast cancer that has received chemo in the adjuvant or metastatic, 1 line of chemo in the adjuvant or metastatic setting, and BRCA positive, same patient, BRCA positive, PD-L1 positive, your choice to go for PARP versus chemo and Pembro, what's your choice?
So first of all, if the patient's coming out from Pembro and maybe a fast relapse, I would say PARP inhibition is the first situation to start with that. If the patients maybe have more than 12 months between early breast cancer situations or never get pembrolizumab, I would start with pembrolizumab and chemotherapy. So we do this in our daily routine.
Another question, you know, the cost is an issue here regarding the immune therapy. Although it's standard of care to go in the neoadjuvant setting to add Pembro with carbopaclitaxel and then AC. But sometimes you are faced with some patient that cannot continue adjuvant Pembro. I know you mentioned some kind of which patient try to or to convince them to continue the Pembro. Is it the pathological CR, the GIL, or the luminal versus basal immune suppressed, basal immune activated? So what's your advice here?
So first of all, what I would say, we only have the data for 1 year. If the patient fits well and it's feasible for the patient, despite of PCR, we give the patient pembrolizumab maybe additionally in the adjuvant phase for 9 cycles. If the patient has strong side effects of some itis, what I'm telling, and pneumonitis, etc., carditis or endocrine failure, that situations of, and we can't give it further, of course, then we have to stop it. We don't have to make scary the patients about that, because they have, after PCR or nearly PCR, they have a really good prognosis. So, but if you have a chance and the patient feels well, I would give it. Of course, if you can't give it, you have to stop it, because the stronger side effects is less than 2%. But if you have this is severe for the patients too.
Dr. Mohammed Salame, he's commenting, you have a great, clear, crystal presentation. Fantastic presentation. He has no question, just a comment on your lecture.
Thank you.
Okay, by this, I would like to thank Dr. Shirko Komel for this excellent presentation. Hopefully we'll see you face-to-face next year. By this, I have to end the second day in our conference. See you tomorrow. Thank you so much, Dr.
Thank you, and many thanks for the invitation, and hopefully we see each other. Many thanks.
Thank you.